Vikramchand Khemchand Seth, a visionary pioneer in clinical pharmacology. This award recognizes exceptional high-impact research conducted in India that contribute meaningfully to the advancement of clinical pharmacology and evidence-based therapeutics. Let us warmly welcome our presenters, each competing for this distinguished honor. We are honored to have with us Dr. Rohit Goel and Dr. Avijit Hajra for chairing this session. Please, sir, join us on the dais. Please have a seat, sir.
So, good morning everybody. I and my co-chair welcome you all to this first oral prize session of IPSCON 2025. A few words about Professor U.K. Sheth. Professor U.K. Sheth hailed from Bombay, Mumbai, and he spent his working life there after a period of training in the UK. He was a pioneer in Indian pharmacology in the sense that he started one of the first full-fledged clinical pharmacology department. It started as a unit under the Department of Pharmacology at Sheth GS Medical College and KM Hospital, Mumbai. And this unit was supported by the Indian Council of Medical Research, and this was one of the first units to do phase 1 clinical trials. And today it has diversified into a full-fledged Department of Clinical Pharmacology at KM Hospital, Mumbai. Now this particular award, the UK Sheth Award, it's a prestigious award of IPS. It has been there right from the beginning, earliest days of the IPS conference, and it is related to clinical pharmacology, not necessarily cardiovascular, and it is presented to young pharmacologists, students and faculty in the early stage of their research careers. So we welcome all the participants. What time is being allowed to them? What time is being allowed to them?
7 minutes for presentation.
So 7 minutes for presentation and 3 minutes for discussion. And I'll request my co-chair to tell you briefly about how we are going to evaluate you.
So good morning, everybody. So we are initiating with the session that is UK Sheth's session, and we have 5 participants from different institutions across the country. So there are different criteria, as sir said, about the time limit is 7 minutes. You should stick to the time, and thereafter we would be having a Q&A session maximum for the 3 minutes, right? So the criteria for the evaluation, that is of 50 marks, whereby we have 5 criteria. One is the content and relevance of 10 marks. Presentation skills of 10 marks, visual aids for 10 marks, discussion and response, that is of 10 marks, and lastly the overall impact. So that may include the Q&A and your interaction with the audience and your defense upon any query from the presentation. So that's all about the criteria. So I hand over to, okay, thank you.
Thank you, sir. It is my honor to introduce our chair for this session, Professor Avijit, Professor of Pharmacology at IPG-MER SSKM Hospital, Kolkata, a distinguished clinical pharmacologist. His expertise spans clinical trials, drug safety, biostatics, and medical education, with an academic journey beginning with his MBBS in 1992 and MD in pharmacology in 1997. He has since contributed extensively through teaching, research guidance, and clinical trial leadership. He has also served the Indian Pharmacology Society as a secretary, clinical pharmacology. We are privileged to have him chairing this session. Now it is also my honor to introduce our chairperson, Dr. Rohit Goel, Professor of Pharmacology at Sholini University, Solan, Himachal Pradesh. With nearly 18 years of teaching and research experience, Dr. Goel specializes in neuropharmacology, circadian rhythm, lifestyle-related disease, including the role of cannabinoids in neuromodulation. He has notable publication, patents, and project grants from agencies such as DST, SERB, ICMR, and CCRAS. Serve as a member of CCSCA, Government of India, as well as British Pharmacological Society. Dr. Goel has also been honored with multiple international awards across Amsterdam, US, UK, Singapore, Japan, and Australia. We warmly welcome Dr. Rohit Goel to chair this session. Before we begin, may I request the judges to kindly move to the designated chair in front area. We will now proceed with the oral presentation. Each presenter will have 7 minutes for the presentation, 3 minutes for discussion. We will ring bell at 5-minute mark and then again at 7-minute mark. We request everyone to kindly maintain decorum and hold applause until the conclusion of each presentation. Now I would like to call the first presentation, Kriti Dubey, speaking from Neel Ratan Sarkar Medical College, Kolkata.
Good morning, judges and my fellow colleagues. So, thank you IPSCON 2025 for giving me this opportunity. My topic for oral presentation is Antimicrobial Consumption Survey in Adult Inpatients of General Medicine Department in a government medical college and hospital in Eastern India. So, introduction, why am I doing it or why I have done it is the antimicrobial resistance. It is a major global public health challenge, majorly because of the injudicious use of antimicrobials. By 2050, antimicrobial resistance could account for nearly 10 million deaths annually worldwide. And India is considered to be the AMR capital of the world. And antimicrobial consumption in India has increased from 3.2 billion to 5.5 billion defined daily dose from year 2000 to 2015. And hospital-based antimicrobial use contributes significantly to the burden. Patient-specific data derived from the medical records may yield more accurate insights into actual antimicrobial utilization and prescribing practices within the hospital. My objectives: to estimate the month-wise prevalence of antimicrobial consumption volume, which is, consumption volume, which is expressed as the number of DDD consumed, and antimicrobial consumption index during 1 year, to measure the total burden or the prevalence of antimicrobial consumption and consumption volume for 1 year, to stratify antimicrobial consumption according to individual agents of different class, to categorize the antimicrobial consumption according to WHO, Access, Watch and Reserve, that is the AWARE classification, to find out empirical or targeted use of antimicrobials, and to calculate the consumption of antimicrobials according to routes of presentation. Materials and methods. Study design, it is a retrospective, record-based, cross-sectional observational study. Study setting, adult male medical ward, both male and female, from General Medicine Department and Department of Pharmacology. Study period, 12 months. Study material, bedhead tickets and case notes of all the patients of both gender, 18 years and above, admitted in the General Medicine ward, and the data was obtained from the record section. Study tool, anatomical, therapeutic chemical classification, ATC, and DDD tool, and WHO Access Watch and Reserve classification tool. Data analysis. Data were captured in a structure case record form, which was then transcribed into a Microsoft Excel. Quantitative variables were then expressed as numerals and percentages. Antimicrobial consumption was quantified in defined daily dose and also in defined daily dose by 100 days to determine the consumption volume and antimicrobial consumption index respectively. Result highlights. Total bedhead tickets which were reviewed was 10,137, which constituted of the male medical ward 5,393 and the female medical ward 4,744. The average number of antimicrobials per encounter, which was 1.73. The prevalence of antimicrobial consumption was 57.91%. Average antimicrobial consumption index for 1 year was 124.84 defined daily dose by 100 bed days. The most commonly utilized antimicrobial agent was ceftriaxone, which was around 38.48 DDD by per 100 bed days, and the least consumed individual antimicrobial agent was clindamycin. It was 0.21 defined daily dose by 100 bed days. Watch group of antimicrobial was the one which was consumed most commonly, that is around 94.40 defined daily dose by 100 bed days, and empirical antimicrobial use was the most common. It was almost 99%, and the preferred route was parenteral over oral route. Next, this is the figure which showed the proportional month-wise consumption of antimicrobial, which showed that in the month of November 2022, it was maximally consumed 72.51% compared to the least it was in January 2023, which was 45.13%. Next is the table which showed distribution of month-wise antimicrobial consumption index, DDD by 100 bed days. Serially it is shown from the month of November 2022 to October 2023. And we have the number of DDDs, the patient days, and DDD by 100 bed days. Next table is the consumption of individual and different classes of antimicrobial agents, and also the aware classification group of antimicrobials. So the first picture showed the ATC, anatomical therapeutic chemical code, then the name of antimicrobial, and in the last column we can see the consumption of access watch and reserve agent, in which the watch category of antimicrobial was the one which was used most commonly. So conclusion, lower antimicrobial consumption prevalence, which was compared with the national prevalence reported by National Antimicrobial Consumption Network Point Prevalence Survey, disproportionate high consumption of third generation cephalosporins and other watch group agents over the access antibiotics, which signifies suboptimal stewardship practices, and predominant empirical use of antimicrobials underscores the necessity for robust hospital-specific antimicrobial prescribing guidelines. These are my references. Thank you. Okay, sir. Yes, sir. So sir, first question, anti-tuberculars were added in my study. And the second one, which you asked me, what was the source? So sir, we got it from the bedhead tickets, which we, oh, sir, defined daily dose, which was the average dose, which was, no sir. Yes, sir, because we have taken this data from the bedhead tickets, so it was also the record base, so we actually could not get the actual insight as in compared to what we have got, like, we have gotten to the ward and directly collecting the data as a primary source, so that would have been a much better, I think, compared to the record-based data which was available in my presentation. Sir, access is the one which should be the first line of antibiotic which should be started, and it is examples are amoxicillin and clavulanic acid. So it is based upon the impact of the antibiotic, the resistance potential. So that is it. Sorry, sir, can you please repeat it? Yes, sir. Uh, s- no, sir, it is generalized for all. Yes, sir. Thank you. Thank you so much.
Thank you, Kriti Dubey. It is my honor to introduce one more chair, Professor Satish Chandra, a distinguished senior pharmacologist and former Dean of RIMS Ranchi, a long-time contributor to the Indian Pharmacological Society. He has served in various leadership and pattern role across IPS academic activities and conferences. With decade of excellence in teaching, research, and clinical pharmacology, he has mentored numerous postgraduate students and significantly strengthened medical academics and institutional development. We are privileged to have your esteemed presence and guidance today, sir. Thank you very much. Now I would like to call the second presenter, Aditya Vikram Singh from Senior Resident Faridabad, presenting on topic Shaping Future Doctors, Impact of Communication Skill Training in Medical Students, Self-Perception. Please come on the stage.
Good morning, respected judges and delegates. My name is Dr. Aditya Vikram Singh, and the topic of my presentation is Shaping Future Doctors, Impact of Communication Skills Training on Medical Students' Self-Perception. Communication serves as a mechanism to foster trust, which is an essential component of patient-physician interaction. Efficient communication improves satisfaction for both patients and physicians, and it helps reduce medical errors, patient complaints, and negligent cases. So the rationale for this study was medical students' ability to communicate effectively declines as they progress through clinical years. Teaching of communication skills is often overlooked during this period. While there is a significant amount of study on postgraduate communication training, there is a lack of empirical evidence about training in the early stages of medical career. Hence, the present study was planned. Coming to the methodology, the study site was Department of Pharmacology, Jawaharlal Nehru Medical College, Aligarh Muslim University. The study duration was 12 weeks, and the study population were communication skill education naive second year MBBS students. It was a pre and post evaluation of communication skills learning intervention using a validated communication skill attitude scale CCAS questionnaire. Prior to its use, formal consent was obtained from the original author, Professor Chola Trees, and the scale was validated as per local cultural and regional norms. The study was approved by the Institutional Ethical Committee and was granted a waiver. And the study tool questionnaire was a 26-item questionnaire in English. The participants were provided with following options to answer the questions on a Likert scale, scoring from 1 to 5. The intervention was 12 weeks of communication skill education comprising didactic lectures and role-play communication with a total of 24 dedicated hours as per part of current CBME curriculum. And students were included in study only after obtaining written informed consent. The inclusion criteria was second year MBBS students above 18 years of age of either gender and who had not received any prior education in communication skills and were regularly attending their second year clinical ward postings. While the exclusion criteria were students with any speech or physical impairment that could affect their ability to communicate were excluded from the study, and students with any health or medical condition that could affect their ability to adhere to the study protocol were excluded. Data was collected at the beginning and upon completion of the study. Pre and post intervention comparison of the same group performed using a pair t-test. For each question, median score along with interquartile range was calculated, and a p-value of less than 0.05 was considered statistically significant with asterisk indicating varying level of significance, and data analysis were carried out using SPSS version 23 software. Coming to results and discussion, this is a study flowchart of my study. Initially, we screened a total of 59 students, out of which 3 were excluded. 2 students declined to participate and 1 student had other reasons. A total of 56 students were initially finalized, and they were given a pre-intervention questionnaire. Then the students were exposed to 12 weeks of communication skill education. Unfortunately, 3 students discontinued the study and were lost to follow-up, and then finally 53 students were analyzed, and out of which none were excluded from analysis. This is a master chart. I'm sorry, the screen is not able to accommodate it fully, but on the extreme left we have the questions that were given to the students. The second is the pre-intervention score, the median score, along with in bracket the interquartile range. The next is post-intervention score, and this one in last is the p-value. We'll discuss it in the subsequent slides. So for the ease of discussion, there are a total of 26 questions, which I have divided into 4 categories. The first category is questions regarding perceived importance of communication skills. Pre-intervention, a majority of students agreed on their significance, although a small percentage expressed doubt. Post-intervention, agreement increased to nearly 100% across all questions. The second category is questions regarding benefits of communication skill. Initially, some students doubted their relevance, but post-intervention, the disagreement dropped significantly, with nearly all students agreeing on its importance. The next category is questions regarding negative attitudes or resistance. Here, post-intervention, there is noticeable decline in negative perception with increased disagreement on statements, questioning communication skill relevance to medical education. And the final category is questions regarding personal engagement with communication skill. Here, pre-intervention, around 75% agreed that learning communication skill is fun, which increased to around 90% post-intervention. Similarly, interest in learning communication skills rose from 81% to nearly 90%. Students demonstrated notable improvement in several key areas related to communication skills. Question 2, I cannot see the point in learning communication skills. And question 8, I cannot be bothered to turn up to communication skills sessions. Both show significant improvement post-intervention, suggesting communication skill training helps students see communication not as an auxiliary skill but as integral part of their medical training. The question 5 and question 10 demonstrated statistically significant improvement, suggesting students in post-intervention phase were more likely to acknowledge impact of communication training on patient interactions. Significant improvement in post-intervention in question 16 indicates communication skill training contributes to a deeper appreciation of ethical and professional responsibilities. The question 21 demonstrated clear increase in agreement among students post-intervention, reinforcing the idea that communication is a skill that requires continuous refinement. Despite overall positive findings, still a subset of students remain skeptical about necessity and effectiveness of communication training. Response to question 6 and question 11 indicate that some students perceive communication training either as time-consuming or redundant. This highlights a common challenge in medical education where students often prioritize clinical and theoretical knowledge over interpersonal skills due to time constraint and pressure to perform academically well. In conclusion, the study showed that short communication skill intervention can make students more aware of the value of effective doctor-patient interaction, including such sessions throughout MBBS course can help build better and more compassionate doctors. While the limitation was this study assessed short-term changes in students' perception, but it remained unclear whether these improvements are sustained over time. More longitudinal studies are needed to draw meaningful conclusions. These were the supportive studies. And this is the patient information sheet and a participant informed consent form which I used. Thank you.
Thank you, Dr. Singh. Any questions?
Yes, sir.
I have chosen the pharmacologists only. Why not the general doctors of other disciplines?
So because in our department, we have a communication lab where we teach students about the importance of communication skills, like how should they communicate to the elderly, how should they communicate to the small childrens. In fact, the importance of communication skill, how to break bad news to the patients, the protocol, which spikes protocol we should follow. It's a 3 months lab which the MBBS students attend. So that's why I selected second-year MBBS students.
Okay, how many MBBS students are there in your college?
Sir, 150.
150, and ultimately you have studied 53
Yeah,
after
correct.
excluding 53.
Yes.
So do you think this study would be adequately powered? Can you generalize these findings?
Sir, we are yet to draw meaningful conclusion from it because I understand it's a very small sample. It should be followed with a bigger sample size for a longer duration in order to draw meaningful relevance and conclusion from it.
So these you are suggesting, these are preliminary findings?
Yes, sir.
Okay. One more question. Our regulatory body, the National Medical Commission, has made it mandatory that IPSCON skill would be for all medical graduates.
Exactly,
Anyone
sir.
who enters a medical college
Yes.
has to come out with a certain degree of
Yes.
IPSCON skills.
Yes, sir, correct.
But in exclusion criteria, you've chosen to exclude students with speech and
Yes.
physical disabilities. So those that goes against the spirit.
I understand, sir, but during my PG years, starting from 2022, ADCOM was not there. So we were teaching communication.
IPSCON was there in 2022.
Matlab, it was not in second year. We were not teaching that in second year.
IPSCON is from first year onwards.
Okay, sir. Matlab, they must be learning it like in
It's
anatomy or-
mandatory. If you are admitting students with speech and hearing disability or physical disability, you still have to teach them communication skills.
Yes, sir.
Okay. Any more questions? Okay. So we thank Dr. Aditya Vikram Singh,
Thank you,
and
sir.
you can call the next participant.
Thank you, Vikram Singh. It is my privilege to introduce our one more chair, Professor T.K. Mandal, a highly respected senior pharmacologist from West Bengal. He has played key leadership roles in the Indian Pharmacology Society and served as a president of its West Bengal chapter. Professor Mandal has contributed significantly to IPSWB academic initiatives, including major programs on diabetes care, medication safety, and was instrumental in organizing in IPS National Conference at Science City, Kolkata. We are honored to have your guidance today, sir. Thank you very much. Now, I would like to call our next presenter, Indrani Devi Sharma from AIMS Guwahati, presenting on hypertension.
Good morning, everyone. This is Dr. Indrani Devi Sharma, and I am a senior resident at AIMS Guwahati, and I'll be presenting on the causal evaluation of suboptimal control of hypertension in patients undergoing treatment. So as, sir, full screen, sure. Sir. WHO has declared that hypertension is the single most important risk factor in the case of cardiovascular diseases. And almost 80% of hypertensive patients who are undergoing treatment have not been able to achieve their suboptimal control or optimal control for the treatment of their hypertension. So this study is based on that. It addresses the question why. The aim of this study was to find out and focus on the factors that would cause people to have suboptimal control of their blood pressures even after undergoing rigorous treatment. The patients included in this study are those patients who have diligently tried to address their situation and hence have come for regular checkups at the primary healthcare center or tertiary healthcare center wherever they have been allotted to go for the treatment. They have at least a record of 2 previous BP readings and have not missed out on their medications on a regular basis. The patients who self-medicate or have taken over-the-counter drugs have been excluded from the study. So when you are speaking about any disease, कोई भी disease बात कर लो, कब manage नहीं होती है? There are 3 reasons only. The first, जब दवाई ना मिले. The second, जब दवाई तो मिल रही है, but तुम उसको ठीक टाइम से ले नहीं पा रहे हो. And the third, जब दवाई मिल रही है, ले नहीं पा रहे हो, but तुम्हारी disease नहीं मान रही है, तुम्हारी body नहीं मान रही है, और उसके साथ लड़ाई कर रही है. So these are the 3 factors. The first is inadequate prescription. The second is obviously inadequate adherence. And the third is resistance. So we will speak about those 3. Going to the methodology of this study, the study was conducted as a collaborative project between NIPER Guwahati, AIMS Guwahati Medicine Department and AIMS Guwahati Pharmacology Department. The 3 departments collaborated together to get ethics committee approval and then go ahead for conducting the study over a period of some 8 months. Patients only with uncontrolled hypertension were enrolled in the study. And those patients also had to have at least 2 previous readings, even if it's from a primary healthcare center. Those patients who did not have any 2 previous readings were excluded from the study. We went on with the study in an exclusive causal algorithm that I'm going to explain now. So as the patients came to the medicine OPD, after getting a record of their previous 2 readings, they were screened and then their BP was analyzed. If they had met the optimal treatment, then they were excluded. However, if they even after treatment, they still had the problem of not having appropriate control, they were enrolled in the study. Then their adherence was checked by Moresky Medicine Adherence Score. When the score was seen to be non-adherent, they were targeted as non-adherent itself. But if the score was more than 6 and it prompted them to be scored as an adherent person, then they were put into treatment adequacy check. When treatment adequacy was checked, there was 2 factors to be found. The first factor was if the treatment was adequate, that means they had been provided all the options that was there in the market and evidence approved, then definitely they were taken up as resistant cases. However, if not, they had not been offered the options of the available options already there in the market and evidence approved, then they were treated as treatment adequate. This is the baseline. Just a sec. This is the baseline of the study groups. Across all three groups, you can see that the baseline is almost all the same. The resistant group had almost only 9 patients, and there were non-adherents had 42, while inadequate management had the highest number of patients, which was 62. A total of some 113 patients were included in the study. This was because the patients who had come there, they were not the ones who were self-medicating, they were not the ones who were taking over-the-counter medication, and they were the ones who, if they did not have any previous 2 readings, because we needed proper record that they have been trying to get their treatment on score, that is why we had excluded them. So the sample size is quite small, but the impact is quite large. In here you can see that the rural population is higher in all the 3 groups, across all 3. This is why, because AIIMS Guwahati caters toward the rural population and has the impact of catering to these population who first go to the primary health care centers, do not get the adequate treatment, are not able to face and achieve their optimal BP, and then they come to the tertiary healthcare center. The same is given in the number of patients and the drugs that are given here. Only 1 drug was prescribed to 27 patients, 2 drugs for some 53 patients, 3 or more drugs have been given to only 30 patients. Diuretic use was very less in only just 44 of the whole 113 patients. So you can see here in the pie chart itself that the number of people who could have avoided their suboptimal control just by modifying some factors are almost amounting to more than 90% of the cases. Hence, the conclusion from the study was that the lack of intensification of their treatment from the primary healthcare prescriber or the prescriber who was on the other end, may it be the tertiary care one also, has been the reason for them to not able to achieve their control of BP. This has given me the chance to talk about what is the need for the timely intensification of the treatment. Many of the people who are there actually treating the patients do not know what are the guidelines that are actually followed for their proper treatment. Patients come to you and then they are just prescribed 1 single drug, or then the power of the drug is kept on increasing, but they are not prescribed on a second regimen. They are not opted for a 3rd regimen where diuretics should have been used, where we have evidence-based proof that they work. So with all this, we need to retrain, reinforce the idea of guideline following in these primary healthcare centers or the tertiary or secondary healthcare centers, wherever any person is handling these patients, to actually encounter these guidelines, go through them, remember them, and then administer them to the patient so that they can achieve their optimal control. Options are available. We should not be the ones for which the patients are suffering. Thank you.
So this is regarding the selection of patients. As you mentioned, the age is 18 and above.
Yes, sir.
Because disease is very found most of the patients from the adult as well as the elderly.
Yes,
So did you find any criteria of inclusion taking such a range of age while evaluating the data?
So we had to include all of them because patients normally in the rural areas, they are not very adherent to the course of, they are not very sincere in their treatment cycles. So what happens is they come for the first checkup, but then when they are called for a review, they don't turn up. So we don't have the proper 2 BP readings, because of which we had to bring up the range to a bigger amount so that we do get the most sincere of patients who have tried their level best to cope up with the treatment that has been given to them.
So one small query about the secondary comorbidity associated to this hypertension. Did you find any of the patient in this class having the any other disease related to the hypertension and close by having the similar treatment for say obesity or maybe any metabolic disease?
So the study is a very big one. There are many other results associated with it. There are comorbidities and others. Also we have studied all factors that are associated with hypertension and cardiovascular disease. Right now my concentration is only on the fact that prescriber awareness and their need for prescribing the particular drugs, the adequate treatment to the patient is far more necessary than the actual patients following through with the treatment, sir.
So, in terms of figures, what was your working definition of suboptimal control?
So, suboptimal control was defined as those patients who had tried and followed their regimens to a T.
In terms of the blood pressure values, because now we have differing values, na?
Yes.
You may say 140/90, otherwise healthy individual, 130/80 for diabetic individual. So what was your working definition of a
So
suboptimal?
that was defined by the Department of Medicine themselves. They had taken the initiative of following through the guidelines and defining those patients and then handing them over to us, telling us that they had not achieved suboptimal.
That's what I'm wanting to know. What was their figure, cut-off figures?
They had taken according to the last AHA guidelines, so below 140/80 was considered as suboptimal. They tried their level best to put up to at least 150/90 also they have taken in some cases where there is diabetes and other comorbid conditions, but otherwise they have taken as a 140/90.
You've used the Morisky medication adherence scale
Yes.
to define adherence, and those who are adherent you have excluded from
Yes, sir.
further analysis. But this Morisky has a 4-item and an 8-item version.
Yes,
Which
sir.
one did you use?
The 8-item version, sir. There were 7 yes or no questions, and the eighth question was a Likert scale question. We used that.
Okay. Any more questions? Okay, Dr.
Thank you so
Sharma,
much, sir.
thank you.
Thank you so much.
Thank you, ma'am. Our next presenter is Dr. Vikram Singh Dhapola from Himalayan Institute of Medical Science, Dehradun, speaking on assessment of analgesic utilization pattern among construction site workers in northern India, a cross-sectional study.
Good morning to respected jury members and my dear colleagues. Myself, Dr. Vikram. And the title of my presentation is Assessment of Analgesics Utilization Pattern Among Construction Site Worker in Northern India Cross-Section Study. Introduction. As we know, the pain is one of the most common cause of the medical condition encountered in the daily life, and it signifies with the interfere with the routine activity. And analgesics are the one of the most common drugs which we employed for the pain management in household and in hospitals also. And these medications, the drawback of this medication is they are widely available as over-the-counter drugs in our market. If we didn't use these drugs inappropriately, it may have certain side effects which include neurological, gastrointestinal, and this. The justification of these studies is this, the reason of conducting these studies that there are many studies conducted across the globe and in our country which mainly emphasize on the pattern of the analgesics abuse among general population, but no one study has been conducted so far, or very few have been conducted, which focus on the pattern on the analgesics abuse among construction site workers, which are the most ideal candidate for abusing this kind of drugs in their daily life. So talking about the aims and objective, the first objective is to evaluate the pattern of analgesics uses among construction site worker and to explore the commonly misused analgesics, reason for misuse, and to assess the awareness of the potential adverse effect among construction site worker in a hilly region. So talking about material and method, it is an ICA approval, after ICN approval, and this was a cross-section study in which we involved the 221 construction site workers, which were randomly sampled from 8 major construction sites in district Almora from Uttarakhand. And this study was conducted in collaboration with the Department of Community Medicine. And we prepared a pre-validated structured questionnaire was used to elicit the response of the knowledge of analgesics, type of analgesics abuse, factors influencing the use of analgesics, and that data was analyzed by using SPSS version 29. And we prepared this questionnaire in the Hindi format because most of the population in that area in Uttarakhand, they were Hindi spoken. So talking about the observation and results, this is the demographic breakdown of the participants. Here we can appreciate that if we talk about the gender, the most commonly gender was male, which constitute the 74.2% of the total subjects. And the most commonly age group which was abusing this analgesics were 25 to 32 years, which constitute 45.7% of the total subjects. And majority of them was the educated up to the middle school. And the average number of hours which was done by them was 12 to 16 hours. These 12 to 16 hours is because most of them, these belong to the low socioeconomic status, and they were doing the job, doing their job at the double shift. That's why the R are very high in that case. Talking about the knowledge, here we can appreciate knowledge of analgesics abuse. When they were inquired about the brands of analgesics known, the majority of the more than half of the subjects were said they know about two brands of the analgesics. And when they were inquired about the source of information regarding analgesics, majority of respond that the fellow colleagues or friends, they were the major source of information for the analgesics. And when they were inquired about whether they were aware about any side effects of the drug which they are encountering, they said no. The ratio was about percentage was 65.6%. This is the pattern of table eliciting the pattern of analgesics abuse. When they were inquired about the duration of analgesics abuse, here we can find the positive finding. In this, the majority of the many of the respondents said that they took the painkillers whenever they are required, and the percentage is 44.8%. Whereas very few of them elicit that they consume this painkillers on daily basis. And the number of, when they were inquired about the number of tablets and capsules they were consuming per day, more than half, 64.7% of the subjects, they respond that they take at least 2 tablets whenever they feel pain. This is the table 3. In this, when they were asked about what is the usual time of taking the analgesics by them, the majority of the subjects were said that the ideal time for them, which suited them for the use of analgesics or taking analgesics, is before bedtime, and it constitute about 48.4% of the total subjects. And when they were inquired about the reasons of analgesics use, the majority of the patients said that the muscle and joint pain. This section was multiple choice. That's why the majority of the patients said, subjects said that muscle and joint pain was the most common reason encountered by them for the use of analgesics. And it is followed by the headache. Very few that said that they also use this kind of drug because to induce sleep, कि उनको नींद नहीं आती. That's why, and the ratio was about 24.2%. It is a continuation of the table 3. When they were inquired about the time interval between feeling pain and taking analgesics, majority of the patients said that after feeling pain, they took the painkiller within 2 hours of the percepting the pain. And the common analgesics abused by them among the study group was paracetamol, and followed by the diclofenac sodium. And at last, we also try to find out the reason, try to explore the reason behind the gender and their demographic variables along the other patterns of the abuse. And it was found that there was a significant relationship between gender and their literacy level, in terms of the average numbers of hours they work, and the brands of analgesics they know, and the duration of analgesics abuse by them. This was found to be significant in our study. Conclusion: knowledge of analgesics and probable serious side effects were not adequate among our study group. Furthermore, respondents were overdosing on analgesics and taking the multiple analgesics simultaneously. Ultimately, this study advocates for a collaborative approach between the healthcare professionals and their community to reduce the prevalence of analgesics abuse and promote a culture of safe medication practices. Thank you. Sir, 221. Sir, we also exclude the patient who are on legitimate prescription. Actually, we get the higher number, but we exclude those patients who are taking these analgesics for some medication, means they have some authentic prescription. So we exclude those patients from this. We only include those patients who are taking over-the-counter drugs from pharmacists or from other shops.
Hello. Thank you. Regarding duration of your research work, what was that?
Duration, sir, it was a 6-month study, and it was a 6-month study, and it was conducted in the 10 different. We located the 10 major construction site in district Almora, and with the help of the community medicine department and by employing their interns, and we also monitor them. We collect this data through in duration of the 6 months. No, sir, it was no summer winter. It was conducted from Jan to June. From Jan, sir, actually the Almora is a hilly region, so throughout the time there will be a winter, and summer is not very high in that area. It's a cold area.
You have said that you are using a pre-validated questionnaire. So how did you validate the questionnaire?
Sir, we validated, sir. So we did a pilot study regarding this. Among the construction, some 5-10 construction workers which are working in our institute, because our institute is a nascent institute, and the construction work is going on in our institute also, which was my previous institute, GMC Almora.
No.
So
what kind of validation have you done? You have done a pilot study, you are saying,
yes,
with
sir.
a small number of
Yes, sir.
construction workers. But
yeah.
what were the validation strategies?
Validation. So we did this study, and this validation part was done by the community medicine department. So
Okay.
I was. Yes, sir. Pharmacist.
I am suffering from this and that, and they give the medicine. Then did you inquire the shopkeepers also?
Sir, no. No.
The patient,
we
they don't know whether they have to take paracetamol or they have to take ibuprofen.
Yes, sir. So no, we didn't do such kind of intervention study among the medical pharmacist. Regarding this, sir, I'm not getting you. Yes, sir. Yes, sir. Sir, can you repeat? I didn't get. So mainly musculoskeletal pain, because they, as I discussed in my presentation, majority are doing in the double shift. So the basic, naturally they will perceive the pain. Musculoskeletal and headache and joint pain, these were the most common problems which was encountered by them and reason for the analgesics abuse among the young population. Because double shift and duration of hour is very long in them. This is the main reason we explore in our study. Thank you.
Thank you, Dr. Vikram. It's a humble request to judges and presenter also. We are running short of time. Just try to be finished as early as possible. Our next presenter is Dr. Gauri Chaturvedi from AIMS New Delhi.
Good morning, respected judges and delegates. The title of my presentation is Cardioprotective Effects of RIPC in ACS Patients, a randomized control clinical trial in Indian population. So, acute coronary syndrome refers to a group of conditions that include STEMI, non-STEMI, and unstable angina. Large body of experimental and clinical evidence supports the notion that reperfusion induces additional damage to the myocardium known as reperfusion injury. IPC, that is ischemic preconditioning administered in an organ distant to heart, has also been shown to confer cardioprotection. In our case, we have given remote ischemic preconditioning to the upper arm of the patient. Vitamin D also plays an important modulatory role as its deficiency is associated with elevated inflammation, impaired endothelial function, increased oxidative stress, and reduced cardioprotective signaling. For the first time, we have investigated the cardioprotective effects of RIPC in ACS patients and explored its correlation with vitamin D serum levels in Indian population. We have analyzed these effects on important cardiac injury markers, inflammatory markers, which has never been done before. So the objectives are as follows. Objective 1 was to evaluate the levels of cardiac injury and inflammatory markers in STEMI patients before and after primary PCI in control and RIPC arms and its correlation with serum vitamin D levels. The second objective was to evaluate the major adverse cardiovascular events during follow-up period in normal and vitamin D deficient patients after the stent placement in control and RIPC arm. And the third objective was to evaluate the echocardiographic parameters during the follow-up period in normal and vitamin D deficient patients after the stent placement in control and RIPC arms. So the inclusion criteria, we have recruited all the ACS patients with STEMI, non-STEMI, which have undergone PCI. Age was more than 18 years and gender both male and female. The exclusion criteria was as follows. The parameters we have investigated is we have measured the levels of vitamin D3, the cardiac injury markers, and the inflammatory markers. So in the methodology part, what we do is the patient comes in the Department of Emergency Medicine, AIMS New Delhi. We randomize the patient immediately into a control or RIPC arm. And after that, we collect its blood sample at 0th hour before the PCI. After that, we give the patient belonging to the RIPC arms the remote ischemic preconditioning to the upper arm. The patient further undergoes PCI, that is percutaneous intervention. After that, we again collect the blood samples at 24 hours after the PCI. And after 1 month, we call the patient for follow-up, during which we measure the echocardiographic parameters. So baseline characteristics, we found that most of the patients belong to age 31 to 50 years. The percentage of male and female was equal in both the RIPC and control arm. And most of the patients had hypertension and diabetes as their comorbidities, along with hypothyroidism, dyslipidemia, family history of CKD, and smoking, etc. So objective 1, we analyzed the levels of these markers in RIPC and control arms. This is not in relation with vitamin D. So what we found is in troponin I, if you look, the levels have increased in both the arms, like in control and RIPC arm, but it has significantly increased in the control arm. In CKMB, the levels have significantly decreased in RIPC arm and significantly increased in the control arm. In CRP, the levels have decreased in RIPC arm, but not significantly, but they have significantly increased in the control arm. In IL-6, we found that the levels have increased significantly in control arm, and in RIPC arm, it has decreased, but not significantly. IL-8, we found that the markers have, the IL-8 levels have increased in the control arm, but they remain almost same in RIPC arm. And in interferon gamma, we found that in control arm, the levels have increased significantly and have decreased significantly in RIPC arm. So this shows that RIPC have, to some extent, provided like cardioprotective and anti-inflammatory role. So this is the result with respect to the vitamin D levels. So we have divided the patients, like you can see under the RIPC arm we have deficient and normal, and under control we have deficient and normal. So in CKMB, we found that the levels have decreased significantly in deficient patients also, and normal vitamin D patients also in the RIPC arm. But in control, if you see, the levels have increased in both the cases, but significantly in the normal vitamin D patients. In troponin I, the markers are more or less same in the deficient patients, but it has increased in the normal patients. In the control arm, they have increased significantly again. IL-6, CRP, and interferon gamma, you can see most of the parameters have decreased significantly in the RIPC arm in the vitamin D patients. And they have increased in the control arm. So in the objective 2, we found that at 30 days post-intervention, no MACE were observed in the RIPC group. In contrast, the control group reported 2 MACE events, including 1 case of non-fatal myocardial infarction and 1 instance of repeat revascularization. There were no deaths or strokes in either of the groups. So we have measured these 4 parameters during the follow-up period, that is LVF, ESV, EDV, and WMSI. We found that there was some improvement in the RIPC group, but all of the, they were non-significant difference between the control arm and RIPC arm. So the study found no significant differences in baseline demographics or clinical characteristics between the RIPC and control groups. IL-6, IL-8, CRP, interferon gamma levels decreased significantly post-intervention in the RIPC group and increased in control group. RIPC was associated with reduced myocardial injury markers, particularly CKMB and troponin I, with greater reduction post-intervention in vitamin D deficient patients. Inflammatory markers including IL-6, CRP, interferon gamma showed significant reduction post-intervention in the RIPC group, especially in deficient subjects again. LVF, ESV, EDV, WMSI improved in RIPC group as compared to the control, though the difference was not significant. To the best of our knowledge in this randomized clinical trial study, we have reported for the first time that vitamin D deficient ACS patients are most susceptible to the ischemia-induced myocardial injury. Moreover, RIPC significantly prevented the myocardial injury after the stent implantation, and this cardioprotective effect of RIPC is highly dependent on serum vitamin D levels. So this study was funded by Department of Health and Research. Thank you for your time.
For quick questions. How did you administer this remote ischemic preconditioning?
So we have used a manual blood pressure cuff. So we have given 3 cycles of ischemia and then reperfusion. So we have provided systole, then diastole.
What was the inflation time? Cuff inflation time?
So 5 minutes inflation and then 5 minutes deflation. Then 3 cycles total.
So
In most. So earlier studies have done like this only by manual blood pressure cuff. So most of them they apply on the upper arm or limbs, like lower limbs also. So this is the method.
So some of the parameters are not showing any statistically significant difference in the preconditioning arm versus the control arm.
Yes, sir.
But then still, how can you conclude it's better? Some parameters are showing improvement, some are not.
Yes, sir. So actually, sir, we are yet to, this is just a preliminary work.
Number of MACE events are too small.
Yes, sir. Yes, sir. So we are yet to recruit like 60 more patients. So like, because I went to Department of Biostatistics, so they have said that this number of patients is like still very small to like conclude anything.
You cannot conclude at the moment. You can just say that we have observed
Okay,
these differences so far. Thank you.
Thank you, sir.
This conclude all oral presentation for UK SET Prize session. We extend our sincere appreciation for all presenters for their exceptional scientific contribution and to the judges for their time, expertise, and thoughtful evaluation. A warm round of applause to everyone. Professor Satish Chandra, Dr. Rohit Gohel, T.K. Mandal, Professor Avijit Hajre have enriched this session with this deep expertise, thoughtful evaluation. Their guidance continue to shape the scientific community and elevate the standard of clinical pharmacology. We are truly grateful for their presence today. We now pause to acknowledge and honor our chairs for their invaluable time and contribution to this session. Please, sir, come on the stage. I request Dr. Manish Jain to kindly felicitate them with a token of appreciation. Avijit Hajre. Professor Avijit Hajre. Professor Satish Chandra. Professor T.K. Mandal. Dr. Rohit Goel. Please have a seat. May the discussion today stimulate new ideas, collaboration, and innovation in cardiovascular therapeutics and clinical research. We request the judges to submit their evaluation sheet. We will be moving to the next session shortly. Thank you once again for your appreciation. participation and sport. Let us continue celebrating scientific excellence, innovation and collaboration. Enjoy the rest IPC IPSCON 2025. Thank you everyone. Now the tea break is left only for the 15 minutes. We will gather again after tea break at 12.
खत्म तूने भी सुन लिया जे तूने कुछ किया और मैं कुछ बोलूंगा ही नहीं ठीक है
लग रहा है सीक्वेंस पता चल पाएगा क्या कि मेरा ओडी गुलाटी में कौन सा मेरा है नंबर ये मेरा फाइनल नहीं नहीं हाँ हाँ फाइनल प्रेजेंटेशन हाँ इट्स क्या हो गया सर
आपने भेजी है
भेजी तो है बट मेरे को ना एक बार मतलब इसको खोल के देखना है कि ये खुल रहा है या नहीं यहाँ पे
ये शायद ना खुले बट आपने अगर भेजी है हमें हमारे को
हाँ हाँ
वो हमारे पास होगी
ओके वही दिखा दीजिएगा ये एक्चुअली इसमें मैंने कुछ मॉडिफाई किया है, तो मैं देखना चाह रही हूँ कि वो ग्राफ्स दिख रहे हैं या नहीं।
वो फिर भेज दीजिएगा। पता क्या है, हमने ना ये वाला तो चल रहा है, आपकी कुछ आई गेस पेन ड्राइव का इशू है कुछ तो।
पेन ड्राइव का इशू है, मैं आपको
क्या चीज़ है, क्या चीज़ नीचे हो जाए सर? सर मत छिड़ना, हमें 2 दिन और चाहिए सर। हाँ, शक्ल नहीं आती। अच्छा ठीक है सर, 1 सेकंड मैं ये वाला तो वो कर लें। आपका किस में है?
मेरा ओडी गुलाटी में है। ओडी गुलाटी नहीं है क्या?
ओडी गुलाटी कल है?
हाँ कल है।
अभी आई गेस डाला नहीं हमने।
हाँ हाँ,
इसमें अपलोड नहीं किया है अभी।
मैं आपको इसको अभी शेयर कर दूँ मेल पे, आपका मेल आईडी है आपका, अभी कर दूँ। इसमें नहीं खुलेगा? ये आपका लैपटॉप नहीं है?
नहीं, आपका मैम ये खुल नहीं रहा है एक्चुअली, वो थोड़ा इशू है।
नहीं वो खुलेगा,
हेलो?
एक्चुअली का टाइम लेगा।
यस मैम। मैम आप टू द, अगर आप निकले हो ना, टू द लेफ्ट आ जाओ मैम, आप लेफ्ट में आ जाओ मैम। आप मैम आपको यूबीएस ऑडिटोरियम पैदल ही है मैम, यूबीएस ऑडिटोरियम दिख जाएगा आपको। लाइक अभी लेक्चर हॉल उसमें 4 में भी कोई नहीं है मैम, फॉर द टाइम भी नहीं दिक्कत। नहीं मैम 4 में भी ना अभी कोई है नहीं, क्योंकि टी ब्रेक है। एट 12 इट विल स्टार्ट अगेन। ओके मैम, जस्ट अपोजिट टू द, वो आपको दिख रहा होगा शायद, लॉ ऑडिटोरियम के अपोजिट में वाइट टेंट वगैरह लग रखे हैं। नहीं, कुछ लोग होंगे मैम वहाँ पे, 4 में तो होंगे कुछ लोग। मैम यूबीएस ऑडिटोरियम, आपको हॉल 2 का बोर्ड दिखेगा, आप लेफ्ट साइड देखते रहना, एक बार हॉल 2 का बोर्ड दिखेगा वहाँ। बस मैं आ रहा हूँ बस। नूर,
इसमें
12 बजे शुरू होना है दोबारा।
भेजी हुई है ये हमें पहले, भेजी तो है मैंने, पर इसमें है नहीं ओडी गुलाटी।
हाँ जी सर, यस सर, सब टी ब्रेक में गए। अरे
मैम 4 o'clock के बाद आए तो चलो।
ये आपने भेजी थी हमें?
हाँ भेजा था मैंने।
फिर इसमें है, ऐसा नहीं हो सकता इसमें ना हो। और मैं बोल रही थी यार, आपको वैसे कल चेक कर। हेलो श्रुति, तेरे लैपटॉप में ओडी गुलाटी वाले हैं कल वाले? कौन है, कहाँ है बता मुझे, खोल के, मैंने खोला हो जा रहा है लैपटॉप। कहाँ पे है तेरा ओडी गुलाटी वाला? हाँ तेरा नहीं है ये, आइसर वाला तेरा लैपटॉप है? आइसर वाला लैपटॉप तेरा नहीं है? अच्छा तेरा लैपटॉप का है यार। वो एक लड़की है, उसको चेक करना है अपनी प्रेजेंटेशन चला के। वो पेन ड्राइव में नहीं है ना, ओडी पेन ड्राइव में तो यूके से है। उनका नाम क्या है इनका? सौम्या उपाध्याय। चेक कर सकते थे एक्चुअली इतना नहीं होता जल्दी मतलब अभी उनको और भी काम में सब ज़्यादा मैसेज है ना हाँ जी हमारा एक और सेशन है अभी हमारा सब भूल गया पड़ा है उसके बाद लंच उसके बाद फिर एक और हमारा देखो ना शेड्यूल देगा का आपको पता लग रहा है इसके बाद भी है सिंपल हाँ जी सब है अब हम नहीं है फ्री और हम कब की चीज़ आज नहीं चेक करते मतलब कब की चल रही है देखो आपको पता चलेगा जी एच के बाद है कोई बात नहीं देखो हमें अभी ये देखो 8:30 बजे है ना आप आओ 8 बजे कल हम आपको चला देंगे ओके ऐसा नहीं है ये नहीं चल जाएगी वो तो उसका फोन पे ना उसको देखते हो जब वो वाइट फिल करके ना देख चेक करना कर रहा है कि नहीं कर रहा फिर ऊपर ही रखना यार ये मैम का लैपटॉप है यार इसमें मैं अपनी व्हाट्सएप भी नहीं चला मैम का अभी तक देख एक काम ये बहुत छोटा दिख रहा है ना हाँ है ना वही मैं सोची तुम्हें बता देती तेरे को तो यहाँ दिखेगा नहीं बस बहुत छोटा ही चीज़ है हम लोग का वहाँ बहुत बड़ा स्क्रीन था ये कुछ भी नहीं दिखेगा ये दिखेगा मैम यहाँ पे हाँ दिखेगा कहाँ दिखेगा ये बहुत बहुत ऐसा दिखेगा छोटा छोटा मुझे लगता है ऐसे भी आपको यस सर
Good afternoon to all the distinguished delegates, esteemed faculty members, respected chairs, honored guests, and dear researchers. It is my privilege to formally commence Symposia 2 entitled Chronic and Metabolic Disease Management. Chronic and metabolic diseases continue to pose a profound challenge to global health systems, contributing significantly to the long-term morbidity, disability, and economic burden. This symposium has been curated to bring forth advanced scientific perspectives, contemporary clinical strategies, and promising research directions in this domain. Today, we have honor of hearing from eminent experts whose contributions are shaping to the future of chronic disease management globally. This session is graciously chaired by the presence of Dr. Abha Kumari. So I request Dr. Abha Kumari ma'am to please join us on the dais. Please ma'am, come on the stage. It is my honor to introduce ma'am. Ma'am is professor and head of pharmacology at the Rajendra Institute of Medical Sciences, Ranchi. She is having more than 30 publications and more than 20 years of experience teaching the postgraduate students. She is deeply involved in academic training, research evaluation, and also serves as an external examination for several prestigious universities. She has chaired scientific sessions at major national conferences, and ma'am is a life member of several esteemed professional societies. I request ma'am to please invite our speaker of today, Dr. Ashay Bhatwadekar. So ma'am, please invite our speaker for the day.
Hello. A very good afternoon to all of you. It is my privilege to introduce Dr. Akshay Bhatwadekar, a distinguished faculty member at the Eugene and Marion Click Eye Institute, Indian Policies, USA. Dr. Bhatwadekar is internationally recognized for his pioneer research on diabetic retinopathy, a major microvascular complications of diabetes. His scientific contribution span disease mechanism, elucidations, biomarker discovery, diagnostic advancement, and development of innovative therapeutic approaches. He has significantly advanced the field of early detection and improved management strategy for diabetic eye disease. His extensive publications record in leading ophthalmology and metabolic research journals underscore the global impact on his work. A committed translational researcher, he continues to contribute towards reducing the vision loss among the diabetic patient worldwide. The title of his presentation is Pursuits of Diabetic Retinopathy, Cause, Diagnosis and Management. So I now invite Dr. Akshay Bhatwadekar to deliver his addresses. Welcome, sir.
Good afternoon, everyone. So, I'm sorry, sir. In the meantime, I'm very honored that Dr. P.V. Diwan has also joined us. May I please invite Dr. P.V. Diwan on the stage. It's our absolute honor to introduce Dr. P.V. Diwan, sir. Sir is a distinguished pharmacologist and founder director of NIPER Hyderabad. Sir is having more than 300 publications, more than 17 patents, and mentored 36 PhD scholars. He's a leading figure in pharmacology. Sir is a fellow of Royal Society of Chemistry and is the first Indian chartered scientist. Dr. Diwan is also a recipient of IPS Distinguished Pharmacologist Award 2023. Sir is currently serving as a research director at Central Research Laboratory. So we are very privileged to have Dr. Diwan as a chair for this session. I thank you, Dr. I thank Dr. Abha Kumari and Dr. P.V. Diwan sir for honoring us with their presence. I request both of you to please join us in front so that we can start with the session. Thank you, sir. Thank you, ma'am. Thank you so much, sir. Now, I will hand over the stage to Dr. Ashay for his presentation. Thank you so much for your patience, sir. Thank you. I think this is not working properly.
Okay, all right. Okay, good. Let's see, what's the time? Well, good afternoon, everyone. And then I guess I need to stand so that I can see it well. Thank you for this excellent introduction, Dr. Kumari, Abha Kumari, and then the gracious presence of Dr. Diwan for this session. And then I would like to also thank the organizers for this event. Yeah, should I take a minute? All right. Well, I think in the wake of time, let me just get started on the time. So, well, I would like to thank the organizers, Professor Anil Kumar, and then my dear friend Dr. Bishnoi for inviting me here, and then share some of the work that we are doing at Indiana University in Indianapolis. So, before I begin, actually, this is a pharmacological society. So I would like to take a moment to really thank my past mentors who had been really instrumental in shaping my career. I think some of you know here who are from pharmacy background. Dr. Kastura, that's where I started my pharmacy degree in MPharm. So I think he really instrumental in instilling the research habits in me. So I'm really grateful for that. And after that, I was at University of Pune. So Dr. Ghole was extremely kind in his lab and then helping me teach things. And Dr. Deshpande to some extent when I was working in the University of Pune, so very kind of that. So with that, let me just start here and open your day with the diabetes. I think I don't need an introduction for the diabetes, and it's such a widespread disease around the world. What we know that about 25.8 million people, they have diabetes, and at least in US, what we know that 8.3% of the US population is having diabetes. Something that is a cost that's important considering all the insurance and other things that the number of problems we face. The direct medical cost expenditure is about $116 billion. And then I think what I tell to all my students and whenever I teach, it's the diabetes is the one thing. What you really need to be thinking about the complications of diabetes. And then I like to really spread these complications into two parts. That's the one is like the major complication that's called as a macrovascular complication, and the other one is called as a microvascular complication. And then the macrovascular complications like heart and like the cardiovascular issues, stroke, those all are the macrovascular. But also there are microvascular complications, which I'll come to that in a bit. But taken together, I think this is the 7th leading cause of the death in the United States, just because of having a disease which is a metabolic, that is kind of a diabetes. And there are microvascular complications when we can typically refer as like nephropathy, retinopathy, and neuropathy. So something, the word I would like to put here is that losing about 7% of the body weight can reduce the 58% risk of developing diabetes. So something very striking figures, and then if you want to read more about, here is the reference, and then I highly recommend. So keep moving and then try to stop the diabetes. On that note, looking at the complication of diabetes. So I already showed you the complication of diabetes, and we talked about a variety of things like the stroke, cardiovascular diseases, Then we have diabetic nephropathy and diabetic neuropathy. Over here, the peripheral vascular diseases, food problems. Apparently, the periodontal disease is one of the reasons that is seen in case of the diabetes. And then what I want to focus here is like the diabetic retinopathy, particularly in the eye, there is a cataract and glaucoma, they are also there. But let's just go look in diabetic retinopathy. So the diabetic retinopathy is one of the most common complications of the diabetes. So if you want to rank neuropathy, nephropathy, the most common complication is the diabetic retinopathy. What we know that there is a $753 million are costing to the Medicare B in the United States for the service that is needed for diabetic retinopathy. A very recent data from 2021 what shows that there is a 9.6 million people in the United States, they have diabetic retinopathy. And then this figure is very striking to me, and then to my surprise that there are a number of people, there is 1 in 10 people between ages 0 to 24, they have some kind of a diabetic retinopathy. So that is very striking. And this is a demographic wise, how United States wise the population is having the diabetic retinopathy changes. Particularly two kinds, one is like the diabetic retinopathy total, and then the vision threatening diabetic retinopathy, when we say that the vision is going to affect. And that rate is also higher, and somehow certain states are disproportionately affected. And there are opportunities for the socio-economic factors, then demographic, and there is a big area of research in that. But something about the Indian population, and then I was trying to look up the literature, and then interestingly, I came up with this article we just published in November 14, So what is a bigger impact than the journal like India Today? It's talking about diabetic retinopathy, and considering that it's such an important condition in India as well. We know that there is a 10.1 crore people have diabetes in India, and then out of them 1.26 crores are having some kind of eye-related complication, and then more than out of them 40 lakhs are at the risk of diabetic retinopathy. So globally it's a problem, and then we need to be really finding treatments so as to whether we can really cure this condition or at least manage these individuals well. So when we look at the diabetic retinopathy, let me tell you a little bit how the lesion of diabetic retinopathy looks. There are two main stages of diabetic retinopathy. The first one is called as non-proliferative diabetic retinopathy, and second one is called as a proliferative diabetic retinopathy. So the non-proliferative is divided into mild, moderate, and severe, and proliferative is just the one stage as like proliferative diabetic retinopathy. Now these are the fundus images across. Under mild NPDR, so this is a fundus image, and what you see, there is this microaneurysm. So around the vessels there is a bulging saccular pouches, so that is the microaneurysms, they are seen into the vessels. And in case of the moderate, you can see more microaneurysms, you can see this yellow hard exudates into the retina. And then there's a severe NPDR when there is a macular bleeding, there are exudates, and this is the stage is very defining from NPDR to PDR, which is called as a proliferative diabetic retina. So what happens, there are new vessels, they form from the parent vessels, so that makes it proliferative condition. Now, little bit more here for understanding how does it look when I do the cartoon here. So over here, this stage is a non-proliferative diabetic retinopathy. I'm sorry, are you seeing my mouse? I apologize. Let's just do this way. Okay, now you can see better, right? All right. So over here, this stage is a non-proliferative diabetic retinopathy, and over here is a PDR. And whatever I was showing you here, it's more cartoonically, it's shown better. That there are coronal spots, there are hemorrhages. So actually, the vessels inside the eye are leaking. And then you see these hemorrhages, so the visual field is getting affected. And then that's why the patient has the problems. And then this is when there is a problem that this is a parent blood vessels and the new vessels are formed. These new vessels are leaky and they ooze blood into it and they proliferate, and eventually in certain cases it happens that they proliferate all over the retina, and what we call as a thing called as a retinal detachment, and that's called the tractional detachment, and at that point it is an irreversible condition. Another thing that which I would like to highlight, it's called as a macular edema. So macular edema is the diabetic retinopathy type which exists at any stage of diabetic retinopathy. It can be mild NPDR, moderate, but the macular edema can exist throughout the disease. So what it is basically, you see all these cystoid things into the retina at the back of the eye. So that is the macular edema which is seen in the patients. So over here is the normal retina. Here you see the retina with the NPDR and with the cystoid macular edema in particular. So just with in the interest of time, like I just want to highlight two things before I finish this introduction for diabetic retinopathy. There are two well-known studies which are really kind of formed the basis for the variety of the treatment guidelines that we do for the patients. That one study is Diabetes Control and Complication Trial, DCCT, and other one is United Kingdom Prospective Diabetic Study. So this was a historic data, but what is important is here is that the tight glycemic control is extremely important for patients to manage their diabetic retinopathy. So when I say that tight glycemic control is like a glycated hemoglobin of 7 or lower. So that's what is a tight glycemic control. When that is managed, then the patients can be better treated for diabetic retinopathy. So what is here, this data, what is showing here for DCCT, what it showed, when the glycated hemoglobin went down from 9 to 7.2, there was a 63% reduction in diabetic retinopathy in DCCT, and UKPDS there was like 17 to 21%. Something to know about these two studies, that why I chose them, because DCCT is on type 1 patients and UKPDS is on the type 2 diabetes. So in both these conditions it is kind of helpful. And it's not only it is beneficial in diabetic retinopathy, other complications of diabetes are also reduced with the good glycemic control. So I gave you a little bit introduction about the diabetic retinopathy. Let's dive deeper and understand the pathogenesis, because one of the things important for the pharmacology is the pathophysiology. Like unless you know the pathophysiology, you cannot really develop the pharmacology. So looking at that, so this is the one thing that diabetic retinopathy, which is called as a pathologic hallmark of diabetic retinopathy. So what you see here is a technique that we do in our lab, and then I think around the world many groups have been doing that. So what we do here is like, this is the eye which is donated in case of the human retinas or the mouse eye. So you remove the sclera, get the retina, and then you stain basically. That's what is a typical technique. And when it is stained, that's what it looks. But this technique is called a trypsin digestion. So what you do, you use a trypsin, and then that way you can get rid of all the neural retina, and what is left over here is a vasculature. And then over here what you see, this is a mouse retina which is stained with the green stain, and this is the mouse retina which is stained with the periodic acid and Schiff's base. And I want you to take a look at these few things over here. Now wherever this blue arrow is, that's called as a acellular papillary, and that is the pathologic hallmark of diabetic retinopathy. Both in human studies if you are doing the pathology samples, and in the animal studies if you are doing the mouse or other rodent or pig or any other. So that's what we call as a vascular retinopathy. There is a whole literature on the neural retina and the neuropathic changes and whatnot. So I'm happy to really talk to you about if you have those questions. And then this is another cell type called as a pericyte, so which is at the periphery of the blood vessels, which is called as a pericyte. And there is this cell which is inside the cells called as endothelial cells. So what happens with the diabetic retinopathy, there is a loss of pericytes, there is a loss of endothelial cells, and that end up leading to a cell, a papillary cell which is not having any cell, and that's what is a cellular papillary. Now what it is basically a naked basement membrane tube. Because of that, these vessels are shut, and then around that the vascular supply is reduced, and that creates the ischemia, and this ischemic condition triggers the release of the growth factors, and that growth factor release there's a next step, that is a proliferative diabetic retinopathy. But before I go into that, let me just show you this. If I cut this cellular capillary further, what you see here is like a naked basement membrane tube. And then this is the place there should have been a pericyte. Now it is gone. This is the state, and there should have been endothelial cell. That is gone. And that is what is leading to a cellular capillary. Now this is a rodent retina. Let me show you what happens into the patient side. So these are the human retinas, and then what you see here is that microaneurysms, what I was showing to you earlier, and this is a trypsin digest image again, what I showed you. And then very particularly they are on the periarterial side. And then you can see these microaneurysms, you can appreciate here all these bulging saccular pouches. Then there is also arteriolar loss of smooth muscles that is also seen in this trypsin digest. And there is what we call as IRMA, so that's intraretinal microvascular arrangements, like so. There is kind of shunting of the vessels that is also seen in some of these sections, and that is also observed. Let's look a little deeper how these microaneurysms look particularly. Now here is a microaneurysm. This is the electron micrography image, and you can see that some of them have the RBCs impacted, and then you see this basement membrane which is really thickened. In some cases there is sclerosis, and you can see the sclerotic microaneurysms on the pathology as well. And in late stage there is a RBC breakdown, and there is a cellular capillary over here, and then very much advanced stage you can see. Another EM image I want you to take a look at here, as one of the important thing is like the basement membrane thickening. Now this is the normal retina, that's the endothelial cell, that's a pericyte, and that's what you see over here. But with the, if I have comparatively this another vessel which is with the diabetic retinopathy, what you see here, there is this endothelial cell is really, sorry, the basement membrane is way thickened over here as compared to the non-diabetic. So that is very peculiar one. Let's just one last slide on the human retina just to get a more idea of the proliferative diabetic retinopathy. And this is a fundus image, and what you are seeing, this microaneurysms again, but you see there are a number of these new vessels which are very different than the parent vessel, and this is the entire retina which is having this proliferative stage. And then this is the fundus showing that this retina is really struggling to really whatever ischemia is there, and as a compensatory mechanism they are producing more and more vessels in order to meet the demand. So this one, why it is happening, I think each one of them will take like hours of talk, like, and when we try to piece together pathogenesis, and this is a multimodal thing, so there is just not the one factor that is happening in diabetic retinopathy. But something to know that hyperglycemia is the one trigger for all of this, and then if that is controlled, the diabetic retinopathy can be curtailed. So for the hyperglycemia, there is like, beside that, what are the number of factors like oxidative stress, inflammation, protein kinase C activation. There is an increase in advanced glycation end products, and there is also the increase in the polyol pathway. And then there is like activation of cytokines, then dysfunction of vascular neurosis, that's ultimately causing because of that. And then there's a neural dysfunction, vascular changes, and then leading to ultimately to vision loss. And these are the stages what I was telling you, mild, moderate, severe, and PTR. And then the microaneurysms, neovascularization, and so on, what I was showing to you. So they all are related, and these all the mechanisms, they play a role. But that is just a one piece in puzzle. There are a number of things that are happening, and then like today I don't have chance to present, but one of the things that our lab does is looking into circadian rhythms. That's one of the mechanisms over here, whether does it have any role in diabetic retinopathy. But let's just move on. And then this is just the one last slide on the pathogenesis of diabetic retinopathy, so as to sum up what I was telling you. For the people, those who are not familiar with the retina, so retina is at the back of the eye over here. That's where the light is coming, and then that's where the photoreceptors, and then that's the way it is getting related to the optic nerve and talking to the brain, and that's the way the visual circuit is working. So what happens in the case of diabetic retinopathy? I welcome you to read this review article, very nice, very well written, to know more about what, beside what I'm going to tell you here. So this is what I was telling you earlier, a capillary, endothelial cell, a pericyte, then there is a microglia and astrocyte which is outside. In that's happening in a normal condition. But what happens with the diabetes? In diabetes, as we know, there's hyperglycemia, there's a lot of cytokines that causes activation of the microglia, astrocytes, and then also there is a release of variety of cytokines like VEGF, CCL2, Ang2, TNF, interleukin 1 beta. It's kind of a cytokine storm coming, and that causes this endothelial cell junctional integrity loss. So these endothelial cells are really tightly bound together by junctional complexes like claudin 5 or like sonacridins. And then when all these cytokines they come in, they start moving away from each other. And because of that, these RBCs, that's carbonaceous, actually that's the reason we see the leakage in the vasculature. Now in more advanced stages, these cells are dropped, I was telling you. Once the cells are dropped, those shut vessels are happening, the acellular capillaries, and that creates the region of ischemia, and then that triggers the whole thing. And then we see the proliferative diabetic retinopathy and so on and so forth. So in general, if you ask me, it's a vascular disease, it's a vasodegenerative disease, and it is also the neurodegenerative disease. So it is like a multimodal disease. But clinically it is classified based on the vascular. Like, so when you do the fundus exam, it is based on the vasculature. So how do we know the diabetic retinopathy? So one of the things that the biomarkers of diabetic retinopathy, how do we know? So there are several of them are published, but none of them is specific yet. And then the attempts are made so that whether we can really find a specific marker. So for the clinical one, I think the well-known factors, as I have been talking over and over, diabetes, duration of diabetes, age, gender, and then blood pressure, skin autofluorescence, these are the well-known markers. Then there are certain biochemical markers like glycemia, then glycated hemoglobin, then variety of growth factors, and there are a variety of molecular markers like RNA, DNA, proteomics, genomics, and so on. But there is no precise marker yet, and then there is a need to have some biomarkers. So our lab has been yeah, I have been given time. All right, how much time I have? 15 minutes left. 5 minutes? Okay, all right. Okay. So, so we started, actually I was getting into my data. Let's see how well I can wrap it up. So we started looking into the biomarker for the diabetic retinopathy. And then we did this study where we had really looked into the signature of a stem cell in the blood. And then what you see here, the patients, those who had the diabetic retinopathy, their signature was very much different as compared to non-diabetics. And then what we see, there is a huge difference, and there is an opportunity. And what we found in them, this microRNA 92A is one of the candidate biomarkers. And we not only looked into that, what we think that these microRNAs are epigenetically changing. So we got the blood from the patients, we got their mononuclear cells, and looked for this microRNA 1792 cluster and matched with the severity of diabetic retinopathy. And then what we see here is that controlled diabetes and diabetic retinopathy, in particular diabetic retinopathy versus control, there is a significant difference. That means this microRNA is having a role into diabetic retinopathy. And then not only that, particularly when we compare with the severe PDR and mild NPDR, there are changes, and this diabetic retinopathy marker is really significant. We also look at that marker into the retina, and then we saw it is downregulated, and then you see that the integrins that it is regulating, that is also working with that in harmony. So right now our attempts are to really find more defined biomarker, and then one of the things that we are looking into the stem cell population in the blood and really trying to find early prediction of diabetic retinopathy. I guess with the interest of time, so I have time to cover the treatments which I wanted to cover. But let's just skip this through, and then I'm going to go to the end part. So what we do in the lab so far concerned is there. So one of the things, let me just show you quickly this study, as and then I'm happy to talk one-on-one. So one of the things what we do, we have used animal models and cell therapy, the cell culture in order to test. Since this is a pharmacology session, like we have used one of the drug called as dapagliflozin, both in animal model and the cell culture. And then we show that basically that works perfectly in diabetic retinopathy. And then in summary, I can show you here, it decreases wound healing, it helps with the cell migration, and then actually improves variety of parameters of diabetic retinopathy. And then finally, the people behind the scene, this is the institution where I work, and this is the lab group that I work on. Some of these faces maybe you are familiar. I'm really grateful for the work that they have been doing. And this is our bigger group at Indiana University. And thank you for your attention. And I apologize for going over the time. Thank you. Do we have time for questions?
Yeah. So very nice presentations, and the, like although the data was like skips due to that limited time. So, but I would like to know about the pathology, which particularly you mentioned that it is linked with the vascular as well as like other neurodegenerative related things. So when we do the treatment longitudinally, like once like there is a high blood glucose level, then some degenerations happen, whether it's a vascular and other degenerations. When we started treatment, will all these mRNA related parameter comes down, or they will remain like be activated for that?
No, I think they should come down. Means they should change down or up. That's depending on what microRNA you are looking. But in the response, they should be dynamic, because it is directly related to the inflammation into the retina. So we expect them to change.
Thank you, sir. It is very informative presentation. So I want to know, once the retinopathy develops, what are the further precautions are taken to prevent the progressions of the retinopathies?
So the one thing is the glycemia, the hyperglycemia. So having a tight glycemic control, that is the one thing which can reduce the chances by almost 60% if they not develop the diabetic retinopathy. For everybody, those who have diabetes, a dilated eye exam every year, that is recommended. And then the referral depending on where you are at. If somebody has the NPDR, like mild moderate, you just wait and watch. If somebody has severe, then at that point they can be intervened with the treatment depending on what they are like. Either they are intravitreal injections, or they can go with the one of these the steroids, or they can go with the laser photocoagulation. But answer to your question, to halt stop is the glycemic control. But also something to know about, like in India is now GLP-1s, right? And then like there are reports with the GLP-1 that the sudden drop in blood glucose actually causes the diabetic retinopathy going up substantially. So those patients, I would say, I would want them to go more often to the optometrist office, at least a minimum, in order to check their eyes, and then make sure that nothing is wrong.
A nice presentation as always. I might have missed, I have a couple of things to discuss. One is with you just told about GLP-1. So all the new drugs which are now in the market for obesity, especially semaglutide and all these. So is this documented evidence or papers related to increase in retinopathy cases with that?
Yes, there is. There are studies which publish they show, but I think we are too early to say that, because the retinopathy is really they look right away, right? A visual acuity or something they have looked at that point. I don't think so there is a long-term damage
The other one I might have missed, that the drug which we talked about, in vitro and in vivo experiments in. So, yeah, what's its mechanism of action?
So like one of the things like anti-diabetics, like I used to teach the pharmacology, I still teach. Like one of the things with the dapagliflozin, it gets rid of the glucose, like it's the sodium glucose transporter inhibitor, which is 90% it is absorption of the glucose happens in proximal tubule in the nephron. So it works over there to reduce the reabsorption of the blood glucose. So that glucose is getting rid of. So we thought like how it is going to be beneficial for diabetic retinopathy. So we used the type 2 diabetes animal model DBDB mice and we gave them to the feed for 6 months and then did variety of eye tests in order to show whether it is working for diabetic retinopathy. And then in vitro we did a scratch wound and
Yeah, per se, it means that the glycemic control is then directly proportional.
It is working with the glycemic control, but something that I would like to highlight, we also did their CBC count because we had blood analysis like us do it. And then we saw their hematocrit was really high when they were getting that by glucose. And then I said, wow, this is striking. Why the hematocrit is such high? And then I read the literature, there's a NEJM article was there, and then in patients as well we see that. So basically it is increasing the oxygen consumption capacity. So the RBCs are getting, so I think retina is getting more oxygen, and that's another way it is working. So there are multiple ways that dapagliflozin, all these SGLT2 inhibitors, they work. We can talk more already. Yeah. So, any more questions? No, I'm personally not aware these are using for the diabetic retinopathy, but root kinases are activated, so in theory it should work for that as well. And I think so. Like Nesprudil and like that's the one you are talking about. I think they should work. But one of the challenges is that like the long-term treatment, like how you are really going to do that, like because the disease is long-term. So how you are going to do that? That's what makes it difficult. Maybe I answered the question. All right. And I will be around if anybody have questions. Happy to answer.
So,
Thank you, sir. We express our heartfelt appreciation to Dr. Ashay for his comprehensive and deeply informative lecture on diabetic retinopathy. Now, I request our esteemed guest, Dr. Ashok Datuselia. Sir is an associate professor from the Department of Pharmacology and Toxicology from NIPER, Raebareli. So he will introduce our next speaker, Dr. Flavian Boucher. So, sir, please introduce our next speaker.
so we are here to honor, welcome. He is a esteemed member of the Faculty of Health Department of the Pharmacy, University of Angers, France. And Dr. Flavian is a distinguished researcher with deep expertise in the neuropathic disorders and pharmacological innovation. His work focuses on developing novel therapeutic strategy for chemotherapy-induced peripheral neuropathy with the goal of reducing treatment-related suffering and improving the quality of the life, particularly in the cancer patients. He is actively engaged in mechanism-based drug discovery, collaborative research, and exploration of the new molecular pathway offering neuroprotective potentials. His impactful contribution to the global scientific community are reflected through his research publication and international engagements. His presentation today is entitled Development of the New Therapies for Management of Chemotherapy-Induced Peripheral Neuropathy. So I invite Dr. Flavian.
So the time for the talk is 15 minutes and the next 5 minutes for the questions round. Thank you.
So we will notify at 10 that 5 minutes left, and then 1 minute before also. Yeah. So okay, that like it's okay. Yeah.
So good afternoon, everyone. Thank you for this introduction. My name is Flavien Bessaguet. I'm an associate professor of physiology and pharmacology from the University of Angers in France. I would like to sincerely thank the organization to give me the opportunity to present my work today, and more precisely my previous work in my previous laboratory. And today I'm going to talk about the development of new therapies for the management of chemotherapy-induced peripheral neuropathy. So the chemotherapy-induced peripheral neuropathy is one of the major side effects of chemotherapy and is mainly observed with different chemotherapy like platinum salts, so for example oxaliplatin, the vinca alkaloids like vincristine, or taxanes like paclitaxel. And in patients, we can observe mainly sensory symptoms like paresthesia, but also hyperalgesia, so a high perception for a noxious stimulus, or allodynia, so a pain perception for a non-noxious stimulus. But there are also autonomic symptoms like blood pressure modification, digestive troubles, and more rarely, there are motor symptoms. So the mechanisms of chemotherapy-induced peripheral neuropathy is mainly depending on the molecules. To summarize, there are some chemotherapies that act on the axons, like taxanes or vinca alkaloids, that act on the depolymerization and polymerization of microtubules. And there are also cell platinums, for example, that act mainly on the cell body. So to summarize, they are neurons hyperexcitability with a high expression of different channels like sodium channels or calcium channels, but also there are metabolic disorders and oxidative stress that is associated with neurodegeneration and mainly for the sensory neurons. But also the chemotherapy can act on the glial cells and for example the Schwann cells that is associated with a demyelination. And one other thing is that when the nerve is injured, the neurons can recruit different cells, and more precisely the immune cells. So there is generally an immune response in this peripheral neuropathy. Today, the current management of chemotherapy-induced peripheral neuropathy is based on two different approaches. So the first is non-pharmacological with mainly electrostimulation, like TENS. So it's the low-intensity electrostimulation for stimulate the gate control and block the noxious stimulus. But there is also a pharmacological approach with topical therapy like capsaicin or lidocaine, and systemic therapy like different antidepressants, so duloxetine, venlafaxine, or tricyclic antidepressant like amitriptyline, imipramine, or clomipramine, anticonvulsivant drugs like gabapentin or pregabalin, that is calcium channels blockers, and opioids. But all these different drugs are in fact often inefficient, but have large side effects. So there is a need to develop new therapies for manage these neuropathies. That's why we studied the renin-angiotensin system that is well known in blood pressure regulation. But there is also a RAS system in the central nervous system, and the activation of this system is associated with a neuroprotective effect in a large panel of different models, like a stroke, for example. And more recently, a RAS system has been identified in the peripheral nervous system and is also associated with a neuroprotective effect following a nerve lesion. As you can see here, the peripheral nervous system, and more precisely the neurons in the DRGs, so the sensory neurons, can express also angiotensin 2 and the receptors of angiotensin 2, like AT2 receptor. So briefly, the renin-angiotensin system is composed by angiotensin 1 that is cleaved by the angiotensin converting enzyme in angiotensin 2. And angiotensin 2 has two main receptors, so the AT1 receptor and AT2 receptors. For these studies, we used ramipril, that is an angiotensin converting enzyme inhibitor, the candesartan, that is an AT1 receptor antagonist, the PD 123-319, that is an AT2 receptor antagonist, and the C21, that is a direct AT2 receptor agonist that was supplied by a Swedish company, so the Vicore Pharma company. And the question was, do RAS modulators have effects on chemotherapy-induced peripheral neuropathy? So first, we developed a mouse model of vincristine-induced peripheral neuropathy because vincristine is a main chemotherapy extracted from Catharanthus roseus. You have a beautiful picture here. And is a treatment for mainly leukemia. But among all vinca alkaloids, vincristine is the most neurotoxic compound. And in patients, we observe mainly sensory symptoms like mechanical allodynia. So in mouse, to induce the peripheral neuropathy, we have administered vincristine daily during 1 week. And 1 day before the start of chemotherapy, we started the different treatments. So the candesartan with an AT2 receptor antagonist, the C21 with an AT2 receptor antagonist, and an AT2 receptor antagonist alone. Then we evaluated the functions of mice, so the motor coordination, the thermal nociception, the mechanical nociception, and the mechanical allodynia at day 1 and day 7. And at the end of the experiment, we quantified the intraepidermal nerve fibers in epidermis and the DRG neurons, and we evaluated the morphology of sciatic nerve. So first, we evaluated the mechanical threshold of mice with the Von Frey filaments test. So you have the picture here. We used different filaments that representing different forces of pressure. And when the mice remove her paw, the force, the filament represents the mechanical threshold of the mice. And as you can see here, the vincristine induces a strong mechanical allodynia from day 1 to day 7. A treatment with candesartan was able to restore the tactile sensitivity at day 7, but interestingly, when we associated the candesartan with an AT2 receptor antagonist, we lost the beneficial effect of candesartan. That's suggesting that the beneficial effect of candesartan was depending on the AT2 receptor activation. And to confirm that, we tested the C21, that is a direct AT2 receptor agonist. And as you can see here, we observed exactly the same result for candesartan. And to confirm that, we demonstrated that the association with C21 and an AT2 receptor antagonist was associated with also a loss of the beneficial effect of C21. To go further, we quantified the intraepidermal nerve fibers in epidermis of the mice with a pan-neuronal marker, so the PGP 9.5. And we quantified also the DRG neurons with another pan-neuronal markers, so the beta-3 tubulin. And as you can see here, vincristine is able to induce strong decreases of intraepidermal nerve fibers density and DRG neurons. And candesartan and C21 treatment were able to counteract these diseases. Then we analyzed the morphology of sciatic nerve of mice, and vincristine induces a degeneration of large myelinated fibers in sciatic nerve, and vincristine induces also an enlargement of axon, because vincristine acts on the polymerization of the microtubules and modify modify the cytoskeleton of the neurons. And for these processes, only the C21 was able to prevent this process. Then we tested another pathway, because we know that angiotensin II can be cleaved by angiotensin converting enzyme type 2 in another peptide, so the angiotensin 1,7, that is able to act and stimulate the AT2 receptor and another receptor, that is the MAS receptor. And we tested here a specific and direct MAS receptor agonist, that is the Bio101, that was supplied by another company, so the Biophytis. Because we knew previously that a MAS receptor activation was associated with an analgesia effect in a model of lesion of the sciatic nerve. So we administrated, as previously described, the vincristine daily during 1 week, and 1 day before the start of chemotherapy, we started the treatment with Bio101. Then we evaluated the functions of mice, and more precisely the tactile sensitivity, and at the end of the experiment, we quantified the intraepidermal nerve fibers, the DRG neurons, and we evaluated the morphology of sciatic nerve. As you can see here, the Bio101, so a MAS receptor agonist, is able to restore the normal mechanical sensitivity of mice from day 3 to day 7. And we confirm that the neuroprotective effect of Bio101 was depending on the MAS receptor, because when we associated the MAS receptor agonist, so the Bio101 with MAS receptor antagonist, so the A779, we lost the beneficial effect of Bio101. To go further, we demonstrated that the Bio101 prevents the intraepidermal nerve fibers and DRG neurons degeneration, and this beneficial effect was lost with a MAS receptor antagonist. Then in the sciatic nerve, we demonstrated that the Bio101 prevents non-myelinated fibers degeneration. In parallel, we developed another mouse model of chemotherapy-induced peripheral neuropathy and a model of paclitaxel-induced peripheral neuropathy. Paclitaxel is a chemotherapy synthesized by several species of yew tree, like Taxus baccata, and is mainly a treatment for solid cancers, like drug cancer or breast cancer. But among all chemotherapy, the taxanes, and more precisely paclitaxel, are the most neurotoxic compounds. In patients, we can observe paresthesia and mechanical allodynia. To induce the peripheral neuropathy with paclitaxel, we administrated 4 times each 2 days the chemotherapy, and 1 day before the start of chemotherapy, we started the treatment with ramipril and an AT2 receptor antagonist. And then we evaluated the functions of mice, and we quantified intraepidermal nerve fibers in epidermis, the DRG neurons, and we evaluated the morphology of sciatic nerve. So as you can see here, the paclitaxel induces tactile allodynia from day 7 to day 13, which is reversible by day 20. So in the figure, it's the curve in red. Then we demonstrated that the ramipril was able to prevent the development of this neuropathy. So it's the curve in green. But interestingly, the association with ramipril and an AT2 receptor antagonist was associated with a loss of beneficial effect of ramipril, that suggesting that the neuroprotective effect of ramipril was depending also of the AT2 receptor activation. So to confirm this hypothesis, we tested the paclitaxel and the ramipril on a genetic model of mice. So the knockout mouse for the AT2 receptor. And as you can see here, paclitaxel induced tactile allodynia from day 7 to day 13 in this genetic model of mice. But interestingly, in this mice, the beneficial effect of ramipril was lost. So we had the confirmation that the beneficial effect of ramipril was depending on the AT2 receptor activation. Then we quantified the intraepidermal nerve fibers in epidermis and in the DRG neurons, and the paclitaxel induces a decrease of intraepidermal nerve fibers and the DRG neurons. And the ramipril was able to prevent this degeneration. In the sciatic nerve, we observed that the paclitaxel induces a decrease of myelinated and unmyelinated fibers density, and ramipril prevented only the degeneration of myelinated fibers. But now the question is, what is the specific mechanisms of ramipril? One possible neuroprotective effect of ramipril is when the ramipril blocks the angiotensin converting enzyme, it stimulates another pathway where the angiotensin 1 is cleaved by the angiotensin converting enzyme type 2 in another peptide, so the angiotensin 1,9, and this peptide is able to stimulate directly the AT2 receptor. But now the question is, what about patients? And we asked ourselves, do patients treated with RAS inhibitors develop fewer sensory symptoms following chemotherapy? So we conduct a clinical trial, so the name was Oncotox Essera. So we enrolled 120 patients, and we divided these patients in two groups. One group with a previous treatment with RAS inhibitors, and one group with no treatment with RAS inhibitors. And we followed the induction of peripheral neuropathy following chemotherapy. So with questionnaires, we evaluated the severity of the sensory neuropathy, the neuropathic pain, the daily activities of patients, the quality of life of patients. We've treated with platinum salts and taxanes, and we also evaluated the pseudomotor functions with the pseudoscan, as you can see here, in hands and in feet. The only thing that we demonstrated is that the patient previously treated with RAS inhibitors develop fewer sensory symptoms when they had treated with a platinum-based chemotherapy. Before I finish, I would like to talk about the human immunoglobulins. So human immunoglobulins are a blood-derived medication from a pool of healthy donors. This is composed by IgG, IgA, and IgM, and these immunoglobulins are the treatment of autoimmune diseases or immune deficiencies. And the main mechanism of actions of human immunoglobulins is based on the reduction of the recruitment of inflammatory cells, the reduction of release of pro-inflammatory cytokines and chemokines, because, as I said in introduction, when the neurons are injured, they can recruit different immune cells. So for this study, the question was, do immunoglobulins treatments have a neuroprotective effect on chemotherapy-induced peripheral neuropathy prevention? And these immunoglobulins were supplied by another company, so the CSL Behring. Then we tested the human immunoglobulins on two different models of chemotherapy-induced peripheral neuropathy, so the vincristine-induced peripheral neuropathy, and another model based on the oxaliplatin. And to induce the peripheral neuropathy with oxaliplatin, we administered 3 times each 3 days the chemotherapy, and we started the human immunoglobulin treatment 1 day before the start of chemotherapy. Then we analyzed the function of mice, and we analyzed the tissue of mice. So we first demonstrated that the human immunoglobulins prevent the tactile allodynia induced by the vincristine, so it's the B in the panel. And human immunoglobulins were able to prevent the neurodegeneration, so the decrease of intraepidermal nerve fibers density, the decrease of neurons in the DRG, and the decrease of myelinated fibers density. In oxaliplatin-induced peripheral neuropathy, we observed two different things. The first is oxaliplatin-induced cold hyperalgesia. That is a typical thing of this chemotherapy. And we also observed mechanical allodynia. And human immunoglobulins prevented cold hyperalgesia and tactile allodynia. And finally, human immunoglobulins can prevent the intraepidermal nerve fibers degeneration because, as you can see here, in this model, oxaliplatin does not induce degeneration of DRG neurons or in myelinated fibers in the sciatic nerve. So to conclude, we showed and we demonstrated that when we block the AT1 receptor with candesartan, we promote the activation of AT2 receptor with angiotensin II that is associated with neuroprotective effect, but a direct activation of AT2 receptor with C21 was also associated with a neuroprotective effect. Then we demonstrated that a blockage of angiotensin converting enzyme by ramipril is associated with another pathway, so with the formation of another peptide, so the angiotensin 1,9, that could be associated with direct activation of AT2 receptor and a neuroprotective effect. Then we demonstrated that the Bio-101 has also a neuroprotective effect with a specific activation of mast receptor. But finally, in patients, the question was is also open because this clinical trial was led on a few patients and in a monocentric study. So we have to contend that with more patients and with a pluricentric cohort, pluricentric study. Then we demonstrated also that human immunoglobulins were able to have a neuroprotective effect in our different mice model. Before I finish, I would like to thank all people that has contributed to this work. So the Hospital University of Limoges and the research team, so and more precisely the Dr. Claire Demiot, the different companies that were supplied the different compounds, so the Biophytis, CSL Behring, and Vicore Pharma. And I would like to thank again the organization of the meeting for the invitation and for kindness. Thank you for your attention, and if you have any question, don't hesitate. Thank you very much.
Thank you, sir. Very informative presentation. Sir, I want to know, only ramipril is very important for prevention the neuropathy. Other groups drugs like the candesartan or losartan, what are the other things?
Sorry, can you repeat the questions slowly?
You said that ramipril is preventing the chemotherapy-induced peripheral neuropathy. What's about the other molecules?
Other molecules? Sorry, I didn't
Other
question.
other drugs.
Sorry?
She was asking about other drugs of the same class. Is it only specific to ramipril or
other drugs?
That's a good question. In fact, there are also different studies about RAS inhibitors in general. So it's well a class effect. So an angiotensin converting enzyme inhibitor has a neuroprotective effect. It is demonstrated in a large panel of different models of peripheral neuropathy, like diabetic neuropathy. And that's the same for AT1 receptor antagonists, so candesartan, etc. Yeah.
Okay, thank
it's
you.
already demonstrated.
Okay, thank you.
Yeah.
Thank you for the wonderful talk. I enjoyed it. My question, I have a number of questions, but the first one is your paradigm was prophylactic treatment. So you were giving it
Yeah.
Have you tried when the neuropathy has developed to see if drugs work after the neuropathy has developed?
To have a curative treatment, in fact, that's the question?
So, like, if you give paclitaxel for the drug afterwards.
Yeah, that's a big question, but for us, we started the different treatment before the chemotherapy, because in the medicine, we know that a patient is able for a chemotherapy. So we would like to have a preventive approach to limit the development of the neuropathy. But we didn't know that it's possible to have a curative effect with our drugs. Yeah.
Okay.
Yeah.
Thank you.
We didn't try that.
Okay, thank you. The second question is a technical. How did you
How did you, sorry? How we evaluated this possibility? There is different tests for this cold hyperalgesia. The first is injection of acetone on the paw, because acetone, when is on the skin, it stimulates the channels of the perception of cold, like TRPM8, for example. And for this test, we quantified the time during the mice leaking or had a freezing of the paws. For here, we tested with a jump test. So there is a range of temperature that decrease each minute, and we quantified the jump of the mice.
Thank you.
Very nice presentation, Monsieur. So, ACE inhibitors, as Ramipil, they are one of the side effects of it is dry cough, as we go through, right?
Yeah.
So that is because of increase in kinins, as they say. So did you look into kinins or any other related things in your studies, or are you planning to?
Any others?
So ACE inhibitors not only inhibit angiotensin converting enzyme, but they also inhibit the metabolism of kinins. That is why one of the side effect of it is called dry cough. That's what we study in this thing. So did you look into any metabolism of kinins, or did you look into kinins as markers?
Not really. We didn't evaluated this part. We concentrated only on the sensory symptoms and the motor symptoms of the mice, and we analyzed the tissue of the mice. This part we didn't evaluated. Yeah. Okay. It's a big question. Yeah. Thank you very much.
Hello, sir. Nice presentation. I have one question doubt that renin inhibitors have a side effect which increases the potassium level in the blood.
What is the mechanism of the neuroprotection?
Renin inhibitors cause a side effect which shows that high level of potassium, which causes the disruption in the neurons formation.
Sorry, I didn't catch the question.
Renin inhibitors increases potassium as in side effects. Due to high potassium, it causes a disruption in the neurons. Have you seen in this perspective? Or?
No, we didn't evaluate this part, but it's really interesting, in fact. But we didn't try and we didn't evaluate this thing. Yeah.
Okay, so thank you.
Thank you. A pleasure.
We extend our sincere gratitude to Dr. Flavian for his insightful and forward-looking contribution to the field of neuropathy management. Now, we will conclude this session. First, we will have the felicitation ceremony. So for felicitating our esteemed chairs, I would like to invite Dr. Manish Jain, Faculty of Pharmacology from UIPS Punjab University, to felicitate our chair. I would like to invite Dr. P.V. Diwan on the stage. Have a seat. Thank you, sir. Now, Dr. Abha Kumari. Dr. Ashok Datuselia. We are honored to felicitate our esteemed chair. Your guidance and vision have elevated the stature of this gathering. We express our deepest appreciation for your exemplary leadership and unwavering commitment. Now it's time to felicitate our speakers. So I would like our chairs to felicitate Dr. Ashay. Dr. Ashay. Thank you, sir. Now, Dr. Flavian Bishay. Yes. Come. Thank you, sir. Thank you, sir. Thank you, ma'am. With this, we bring Symposia to Chronic and Metabolic Disease Management to a formal close. On the behalf of organizing committee, we express our deepest appreciation to our respected chair, our distinguished speakers for their exceptional contribution, all members of the audience for their attentive participation. We trust that the deliberations of this session have enriched our collective understanding and inspired us for further commitment for the advancement of chronic and metabolic diseases in their research and care. Thank you. Now we'll proceed to the lunch break. The next session will be at 2:30, so we'll gather back again here at sharp 2:30 for the next segment of the program. Thank you so much, everyone.
presenters? For the presenter? Rajkumar Tulsami, Rajkumar, Dr. Rajkumar. Yogendra, Dr. Yogendra. Rajkumar. First is Dr. Rajkumar, Dr. Yogendra, Dr. Abdullah, Dr. Ravindra, Dr. Rishikesh, Dr. Chandan Chauhan, Dr. Balwinder Singh, Dr. Sandeep Auti, who? Sandeep? Shall I start, sir? Good afternoon, respected judges, esteemed delegates, and fellow researchers. A very warm welcome to the Gufic Prize session for oral presentation in cardiovascular research basic here at IPC IPSCON 2025, being celebrated under the theme Empowering Young Minds to Transform Pharmacology for Viksit Bharat. This session highlights cutting-edge basic and translational cardiovascular research that serve as the foundation for future therapeutic innovations. Through molecular discoveries, mechanistic investigations, experimental breakthrough, these studies advance our understanding of cardiovascular pathophysiology in meaningful ways. The Gufic Prize celebrates impactful research grounded in the indigenous medicine of India, reflecting the Indian Pharmacological Society commitments to integrating traditional knowledge with rigorous scientific validation. We now invite the outstanding competitor whose work has earned them a place on the distinguished platform. We are honored to have with our distinguished chair, Dr. Mukesh Nandave. It is my privilege to introduce our esteemed chair, Dr. Mukesh Nandave, Associate Dean, in-charge Director of the School of Pharmaceutical Sciences and Head of Pharmacology and Pharmaceutical Biotechnology at DIPSRU, New Delhi. A distinguished pharmacologist with a PhD from AIIMS and postdoctoral training from the Ohio State University. Dr. Nandave has over 2 decades of impactful research in nutraceuticals, phytoconstituent and cardiometabolic disorder, with more than 120 publications, multiple patents, major research grant, and prestigious award, including Professor S.C. Larry Oration and GHRE Gold Medal. He continues to play a key role in National Scientific Committee and societies. We are honored to have your esteemed presence and guidance today, sir. Thank you very much. also my privilege to welcome Ms. Dr. Pyodi Dhar, founder and president of the Kolkata Nurture Foundation and chairman of Valmiki Healthcare Private Limited as a chair. A distinguished clinician, educator and healthcare leader, Dr. Dhar has made impactful contribution to universal healthcare access, community outreach, psychiatric services and medical equations. We are honored to have you with us, sir. Thank you very much for your presence. Sir, next year. Who is next year? Each presenters will have 5 minutes for their presentation and 3 minutes for the question session. We request everyone to maintain the decorum and extend full support to the presenter. Now, I would like to call 5 minutes. 5 minutes for the presentation. We are short. We have to conclude 9 presentation in 1 hour. I would like. Yes. But in that session, there were only 5 presenters for 1 hour. I would like to call Dr. Rajkumar Tulswani from DPAS DRDO, Ministry of Defense, Delhi.
Just no mic? Good afternoon, everyone. I shall be presenting some of the work done in the hemodynamics changes and expression of hypoxia signature marker in rat heart exposed to hypobaric hypoxia. And the role of cordyceps sinensis, a medicinal mushroom growing at high altitude. And the cordyceps sinensis mushroom, a medicinal mushroom growing at high altitude. High altitude poses a serious issue with the failure of right ventricle systolic pressure, increase in the right ventricle systolic pressure and failure of the right failure. There is an increase in pulmonary vasculature in the lung that makes the resistance to the heart, and the heart goes to the afterloads. This creates to the PHP condition in the heart, and there is a hypertrophy of the right ventricle. This right ventricle poses a serious issue to the armed forces in the army and in also chronic hypoxia diseases. So there is a thickening of the right ventricle, and hypertrophy causes failure of the heart. This is a cordyceps sinensis, is a medicinal mushroom, grows on the high altitude on the insects and the anthropods. And there are lots of medicinal benefits known for the 200,000 years. We have investigated in the last decade, and we have proven that it to be highly effective in the high altitude conditions. This is the extract has been standardized with the phenolic content, flavonoid content, and the antioxidant activities. Lots of molecules has been identified and standardized in respect to the cordycepins and the polysaccharide contents, and lots of molecules. So this is for the batch-to-batch control. Coming to the actual studies, this is the after 7 days of hypoxia, you may see there is a change in the right ventricle systolic pressure and MAP, and there was the hypertrophy set with the change in the right ventricle to the left ventricle plus septum ratio, and with the treatment with the cordyceps sinensis, all the parameters were controlled with the dose-dependent manner with 100 mg per kg. Coming to the lungs, there was narrowing in the artery. There was a smooth muscle infiltration, muscle purification, and the inflammatory cell infiltration with the narrowing of the arteries in the hypobaric samples. And this was controlled with the treatment with cordyceps sinensis. Coming to the blood parameters, if you go to the PO2, that PO2 was found to be compromised, with the saturation was found to be compromised, lactate was found to be high. This all was controlled with cordyceps sinensis. Coming to the 2,3-DPG, the levels were further augmented with the treatment of the cordyceps sinensis, which shows that it also helps in the good oxygen saturation. It also was working through the augmentation with the RBC and hemoglobin levels with the 2,3-PG, so that the oxygen carrying capacity was supposed to be increased, and it was increasing the carrying capacity also, and also was preventing the afterload from the right ventricular pressures. In most of the electrolytes and the metabolites, glucose, these all were altered with the exposure of the hypobaric hypoxia for the 7 days, which were neutralized with the treatment with the cordyceps sinensis. Coming to the stress on the right ventricle, the levels of MD was found to be increased. Total antioxidant status was TAC was found to be compromised, and the ATP was found to be decreased, and the NADP ratio was found to be compromised with the treatment with the exposure of hypobaric hypoxia for the 7 days in the simulation chamber. And now these all parameters were restored with the hypobaric hypoxia in conjugation with this treatment of CS100. Coming to the liver, because the another issue with the right ventricular failure is the HAPE, high altitude pulmonary edema at the high altitude. So we need to find that how both are interconnected, pushing load to each other. The inflammatory response through the lung was calculated. IL-6, TNF alpha, and the alpha NF kappa B was found to be highly elevated, which was controlled with the treatment of this. So the lung was also being rescued so that it was not paying any afterloads to the RV, and both were contractile controlled with the treatment of CV. Coming to the hypoxia signature marker, whether it was down-regulating that marker or not, because it is essential to see the drug should restore the hypobaric markers. So HI was found to be regulated, VEGF was higher, and NF kappa was higher, and EPO and FTO. All the panel of signature markers were found to be higher, elevated with the hypobaric hypoxia. With treatment, all were restored. NRF2 except NRF2 found to be augmented with the CS, which clearly impacts that NRF2 is an antioxidant resistant molecule, is the elementary transcription factor which regulates the antioxidant status, which clearly shows that it controls all the mechanisms that because it's a non-specific drug, it controls the oxidative stress, inflammatory, so that it controls the systemic level, so that the reduce on the the lung is controlled, and the lung do not pushes any toward load on RV. So overall, if we see at the multifactorial, the drug approaches with the multifactorial issues. It controls the oxidative stress, inflammation, and the RV dysfunction. It restores the hypertrophic factor and prevents the RV dysfunction related to hypobaric hypoxia. In turn, it reduces both of the bases, also maintains cellular bioenergy molecule, redox, and the EPO levels also. So it was controlling the root cause, hypobaric hypoxia, low oxygen scenario. So that the whole scenario, if it is controlled, it reduces the pressure on the lung. That was making it so. So these are overall the outcomes. This drug poses as a new regimen because hypobaric hypoxia is a different scenario. So you do not have the synthetic drugs because it is the body is metabolically compromised. So if you do any allopathic drug or something, it will have the side effects of the one or the, like you do antagonists, agonists, so they have their own challenges. So this provides you the rationale for using cordyceps sinensis for having the healthy performance at high altitude. Thank you, everyone. markers. This one. Because we have to do the angiogenesis, because in hyperbaric hypoxia, angiogenesis helps, but in cancer it is different. So we have to use the antagonists or the agonists, what we have to control them. We have to inhibit them. But
here it appears that it is controlling the VEGF values.
It's basically restoring that value, not controlling it. Like VEGF, there are, this is reducing it. So we are not able to still pinpoint why.
So if that is the case, why did you take VEGF here?
This is all a signature marker. What we have to
What is the relationship with cardiovascular?
In cardiovascular, usually we avoid angiogenesis, but here it is reducing angiogenesis. So in terms of cardiovascular disease, it is reducing, it is effective. But for other organs, like in a systemic pressure, we just help to get more vessels. So that in lung or somewhere you have more vessels, so you have a backstop situation. So in terms of lung, we have a VEGF increase want to be effective, but in heart, it is not so effective.
Yeah, can you come to your histology slide? Okay, what you are explaining, because one thing is missing, there is no scale bar actually in this particular slide. Yeah, that would have been there. And I did not find any, because I think with your CS100 treatment, because that is your missing actually, I think, when you are explaining. Yeah, okay, just take care actually, because that should not be there. Okay, that's fine.
So response you found in a hypoxia situation, do you expect the same effect in a ischemia kind of situation?
We won't be able to comment on that here. What we feel when extreme condition is there, and some drug is working on the extreme, we believe that it should work in the normal. Like in a, because this is extreme altitude, 25,017,620 meter is an extreme case. If it is working in the extreme cases, so what we presume from the scientific basis, it should work in the normal clinical system. It should help. And
Okay.
also in IPSCON, we can try and test in the alternative therapy. You have your standard therapy, you give it an adjuvant to that therapy. It might work.
Okay.
Sir, you have said that, extending to Dr. Ananda's question, so you are talking about hypoxia in hyperbaric situation. I extremely clearly accept that it is an emergency, it is an extreme situation, but you should understand that the primary integral stimulant of any action of blood flow or anything, you were talking about VGF, NFK beta, anything, the primary thing is hypercapnia. When the extreme condition changes, the hypercapnia also gets corrected. So once it is working in extreme condition, does not necessarily necessitates that it will also act. But you have rightly said it might act as an adjuvant. Yeah, thank you.
We don't have data to
Right.
strongly support that, but we believe in this. Thank you.
But we need data, right?
Thank you everyone.
Thank you. Thank you.
It is my privilege to introduce our esteemed chair, Dr. Shubhadeep Debarta Sinha, Senior Vice President and Medical Director at Hetergo Drugs Limited, where he leads clinical trial, medical affairs, and pharmacovigilance. An accomplished physician with an MBBS from GSMC and KEMH and an MD in medicine from BYL Nair Hospital, he further holds advanced qualification in infectious disease, diabetes, and a PhD in public health. With over 2 decades of global experience in developing generic, biosimilar, and new chemical entities across key therapeutic areas, including oncology, cardiovascular and infectious disease. Dr. Sinha bring exceptional expertise and leadership to this session. We are honored to have him as a chair. Now it is also my privilege to introduce another chair, Dr. S.S. Sharma is a distinguished professor of pharmacology and toxicology at NIPER Mohali with over 25 years of teaching and research experience, a PhD from AIMS and a former postdoctoral fellow at the University of Illinois at Chicago. He is a fellow of the Indian Pharmacological Society with more than 190 publications, 7,000 plus citation, and significant contribution in CNS disorder, diabetic complication, and cardiovascular research. He has guided over 120 students and completed 20 plus funded projects. A recipient of multiple national awards, he has also played key leadership roles in IPS and has organized several major national and international conferences. Now it's time to invite our other next presenter, Yogendra Nayak, Dr. Yogendra Nayak from Manipal College of Pharmaceutical Sciences, Mahe, Manipal.
Thank you. Good afternoon. I am going to present my topic, amelioration of bleomycin-induced pulmonary fibrosis in rats by Swarisha Cherata, evidence of TGF-1, beta-1, TNF-alpha modulation. This work is carried out in our department by Mr. Bharat, who is a PhD scholar. Okay, sorry. So it's a work carried out in Department of Pharmacology, Manipal, where Mr. Bharat has carried out this work, and others it's a collaborative research from bioinformatics department. We have put a lot of bioinformatics tool there. Basically, when you look at the pulmonary fibrosis, it is an inflammatory lung disease, especially because of damage in the epithelial membrane because of oxidative stress and EMT, epithelial mesenchymal transition, where exactly the cause is not correctly known, but they say that chronic exposure to the cigarette smoking or the exposure to the environmental toxin or infectious organ. COVID was said to be the main cause for the lung fibrosis, but as it was expected that a huge population will be there in lung fibrosis, and that time we applied for a grant for ANRF. We achieved that grant, and the person who worked under the same project is Vishnu Sai. So they have combinedly worked this together. What is actually happening here is, because of too much of inflammation, we thought we'll screen some of the natural products, especially this product was Swarisha Cherata, is used in traditional medicine, which is specially used in Ayurveda and other conditions, especially for the respiratory condition. We applied several network pharmacology and molecular simulation methods, and we found this is a target for that, especially the TNF-alpha and NF-kappa-B. And the basic objective is to screen Swarisha Cherata in bleomycin-induced pulmonary fibrosis in rat, assessing a molecular mechanism. That's an objective. And to induce the pulmonary fibrosis, we have given bleomycin 3 mg per kg dose oropharyngally through the respiratory tract. It enters the lungs and induces pulmonary fibrosis by 15 days. And analyzing the fibrosis in selected animal, like 6 animals we killed, and see whether the induction has happened or not. After induction, we randomized into grouping, and these are the different groups we have treated the animal. Especially the control group, we have used nintedanib, that is the officially used drug. And there is one more drug, of course, they have a lot of side effects. And tested is a natural product is definitely having advantage. So we wanted to test this with 200 mg and 400 mg dose of Swarisha Cherata extract. And this is what we did. In 13 days, we analyzed, because the oxygen capacity, exchange capacity will be less. So there will be exercise endurance will be there. So that's the reason we have gone for this treadmill test on 13th day. And after that, we found it is significantly inducing, there is a decrease in the exercise endurance. And then we randomized and started treating. And also we killed several animals, that is 6 animals, and we saw that inflammatory markers like neutrophil count in the bark, and also the morphology. When we check, there is a lung stiffening and rapid, rigid, and also vascular congestion, and noticeable reddish brown hue was there in the histology. So that confirmed us to randomize and treat in different groups. Here is what we did is on 28th day, again we studied the same endurance test, treadmill test on 28th day, and 29th day we killed the animal and sacrificed in the way. So that is what we found it as significantly, that means there's actually a lot of endurance was there, and it is protected by treatment with the Sriracha cerata. And then we also seen the expression of different protein by what is called a Western blot, and we found that TGF-beta, especially phosphate NF-kappa B was significantly inhibited by the drug that is Sriracha cerata, but it is significant at higher doses, especially 400 mg per kg, is significantly inhibiting the expression of protein. But when you compare this LPO, there is not much, but however in 400 mg it was showing good results. Then we went ahead with the histology analysis. There we found a significant difference in the parameters that are assessed by making this blind and then assessing the scoring using Ashraf scoring, and then we found that there is a significant difference in the parameters of histology also. And neutrophil count also, there is a significant reversal to bring it to the normal level of neutrophil count after the treatment with Sriracha cerata, especially the 200 and 400 micrograms. However, lung index is not significant difference. So with this, what we confirmed, there is a lot of other tests also we did. However, because constraint of time, I thought I'll end up sharing the conclusion. Sriracha cerata down regulates TNF alpha, NF-kappa B, and it is anti-fibrotic, especially test it does it because of oxidative stress inhibition, inflammatory responses inhibition, and accumulation of collagen is inhibited, and modulating pro-fibrotic factor like TGF-beta 1 and TNF alpha. It suppresses EMT, that's why epithelial mesenchymal transition, fibroblast proliferation, myofibroblast differentiation. So with this inference, we put a lot of in silico tool like prediction of what are the content and how they act, and we come out with the lead like cilidofolin and chiratol, swarishamerin, genshobicron, and mangiferin. These are the lead we have identified, which can be taken forward for the further study. That is what we are going to do now. With this, I end my presentation. Thank you. This is a thank you slide. Thank you. Yeah, it's here. Yeah, that is what we have done other part. It is in vitro in the cell line. And that's correct, sir. But overall result is this, what conclusion is. Sorry for that, yeah. Thank you. Okay. Yes. No, that is done in lung, lung trituration and lung orally. Sriracha cerata is orally given, whereas bleomycin is given oropharyngally. Yeah. Yeah, that's what it is mentioned. Yeah, here. With the, yeah. No, not significant, but in 400 degree, it is 400 mg per kg, it is. Yeah, here. Okay. No, it is percentage is based on how neutrophils are counted, like for percentage only. Total neutrophil, when you can count, it comes as a percentage because there are multiple. Okay. Yeah, yeah. So it will be. Yeah, yeah. So the previous one, this one. Okay, yeah, here.
Magnification level 32x, 127x.
Yeah, it is clubbed together. Both pictures are clubbed.
What is the basis of selecting this nintedanib as a standard?
Nintedanib. Nintedanib is officially used for the treatment of, interstitial, what is called as idiopathic pulmonary fibrosis. It's a disease classified, and it is used as a standard drug by USFDA. Yeah, no, but even then the mechanism also matching because it also has a antioxidant, here also antioxidant, it also inhibits cytokines, here also it inhibits cytokines.
What is the basis for dosage?
It is from the literature. For the Swarshya it is from the literature. No, but because the yeah.
So why did you start at 200? Why not at 100?
200 and 400 is selected based on the literature. That is the basis is it's published work. It is there in the literature. So based on that, it was selected. Thank you. Thank
you. Our next presenter is Abdullah Sharikar from School of Pharmacy and Technology Management, SNGU, Dhule.
Good afternoon, everyone. Respected jury members. Myself, Dr. Abdullah Sharikar, working as an assistant professor at SNU SVK NMIMS Global University, Dhule. My today's topic of the research is naringenin attenuate the TRPM3 mediated neuropathic pain via PAG modulation, that is periaqueduct gray, and neuroinflammation suppressions. Now the first is the introduction. Actually, neuropathic is a chronic medical condition which is associated with the impaired somatosensory functions, particularly in the nerves, somatosensory nerves. Next one is the, it is a heterogenic medical condition which is characterized by the neuronal condition as well as the characteristic symptoms like the allodynia and hyperalgesia. Why there is need to study for this work which is undertaken. Actually, the chronic neuroinflammation which disturb the descending pain pathway, particularly inhibitory pathway in the PAG nucleus, which increase the spinal and nociceptive transmission and which causes the neuroinflammation and leads to the neural plasticity, particularly in the PAG. So we thought that the overexpression of the voltage gated, particularly TRPM3 channels in the PAG could be a good target for the treatment of the neuropathic pain. So we have taken this PAG nucleus expression, particularly TRPM3 expression in the PAG nucleus. Now the aim of the study is to investigate the role of TRPM3 channel, particularly in the PAG, which regulate the neuropathic pain, and second one to assess the TRPM3 expression changes in the PAG during the development of the time course of the neuropathic pain. So material methods, first The in silico molecular docking study was carried out, and the PDB ID is for the TRPM3 channel is the 8DDS. The animal used, these were these male Sprague dolly rats weighing 250 to 300 grams. The neuropathic pain was developed by the well-developed model, that is Bennett, the chronic constriction injury model. And last one is the ELISA and the immunohistochemistry of the PAG nucleus was done to check the various expression of the, level of the neuroinflammatory markers. Material methods, the day after the development of the surgery, 14 days after, the confirmation of the neuropathic pain was done, confirmed by the estimation or the doing the behavioral parameters. And from 15 days, we have taken the, we have given the naringerin 30 mg per kg body weight intraperitoneally per day. And last, at the end of the 28 days, behavioral parameters were tested and followed by the preparation of the homogenate of the PAG nucleus. So grouping is the group 1 is considered as the sham control, where only ligation of the only superficial muscles were ligated, but not the sciatic nerve. Second one is the where the sciatic nerve is ligated, and third one is the CCI ligated plus treatment with the naringenin. Parameters evaluated: behavioral acetone test for the cold allodynia, pinprick test for the mechanical hyperalgesia, and hot plate test for the mechanical cold temperature. The tissue homogenate parameters were evaluated as the TNF alpha, and then interleukin 1 beta, and the IHC of the PAG nucleus was done to check the expression of the TRPM3. Now the immunohistochemistry protocol. First, the PAG nucleus was suspended in the subjected for the cryoprotection for alternate days for 3 days with the treatment with the 10, 20 and 30% sucrose, followed by the coronal section of the PAG nucleus with the diameter of 30 micrometer, and then these were treated with the primary antibodies for overnight with the rabbit anti-TRPM3 antibodies. Then this process is followed by the treatment with the secondary antibodies conjugated with the anti-rabbit IgG staining, and followed imaging on the Leica fluorescence microscope. Statistical analysis was done by the ANOVA, followed by post-hoc bone Ferroni test. Now the result, molecular docking. See, naringenin shows binding affinity, particularly -7.0. Actually, the other binding energy for the other test drug is under investigation. Already we have taken, but first we have taken for this. Here only I have given for naringenin only. This is the behavioral parameter. The CCI induced animal shows decrease in the decrease in the cold allodynia test, and in the pinprick also and hot plate test. But the treatment with the naringenin improve the povidral latency as well as the povidral threshold, respectively in the acetone test, pinprick test and hot plate test. This is the inflammatory cytokines. The CCI-induced animal shows increase in the both interleukin 1 beta and TNF alpha level, and followed by the treatment, the naringenin inhibited the reduced the level of these inflammatory cytokines. And last, the TRPM immunoreactive in the PAG, it shows that the CCI-induced animals particularly shows overexpression of the TRPM3 channels in the PAG, whereas the treatment with the naringenin decrease the, slow down the expression of the TRPM3 channels. Discussion. The CCI-induced neuropathic pain activate the TRPM3 expression in the PAG, which is associated with the thermal and mechanical hyperalgesia as well as the cold allodynia, and which causes the neuroinflammation and dendritic degeneration. And the naringenin reduce the sensory as well as the affective symptoms of the neuropathic pain. This is our hypothesis, where the TRPM3 is acting on the TRPM3 channels, which reduces the inflammatory cytokines. Conclusion. TRPM3, targeting the TRPM3, particularly the PAC, reduces the sensory as well as the affective pain, which is characterized by the behavioral symptoms. CCI-induced animal model shows the hyperalgesia and allodynia, as well as the neuroinflammation, as well as the dendritic injury. Naringenin, this is a TRPM3 inhibitor which shows the partial restoration of the PAG, and TRPM3 modulation is a promising neuropathic pain therapy as a target. These are my references, and these are the some procedures which followed and the kit we are used. Thank you.
Yeah, thank you, Dr. Abdullah. I have a question actually, like you have done this neuropathic pain model, which is generally like sciatic nerve damage is there. So why did you measure actually in the brain, TRPM3 level in the brain? How it can be correlated?
It is a descending inhibitory neuropathic pain. I have to target for the it is associated symptoms.
No,
it's
but
associated.
actually you would have
but
also
first
shown
my
in the
target
sciatic
is
nerve actually
yes.
whether there
Yes.
is an alteration of TRPM3 in the sciatic nerve.
Yes.
Another question, actually, I think you did not go for this mechanical and
Mechanical, it is
no,
done by pinprick
like I'll
test.
tell you, Bonfrey, Randall, Salito.
It is under process. That's why I
Under
told you
process,
this
yeah,
is
because these are
this
the
work.
two tests actually like
Yes,
which
yes,
are reliable tests for
yes,
this thing actually.
Bonfrey test.
And yeah, why didn't you measure motor nerve conduction velocity?
It is also under consideration. We have
Under
taken this,
consideration.
but
No, you have completed the
no,
study.
sir.
But
First,
you
my
are saying under
no,
consideration.
Actually, my first aim is to show the expression of the PAG in the expression of the TRPM3 in PAG only.
Okay,
on
just
this work I have taken undertaking.
Just one
for
GK
this.
question actually.
Yes.
Can you name the scientists who got Nobel Prize for TRP
Last year,
discovery?
TRPM, capsaicin ion channel. Last year, one of the American.
No, can you name
scientists.
those scientists, Nobel laureate?
But I assure that last year it was capsaicin. For the capsaicin, it was awarded. Thank you, sir.
Thank you, Dr. Ravindra Jarg. Our next presenter is Rishikesh Bachao from RG Sapkal College of Pharmacy, Nasik.
Good afternoon. Good afternoon, respected dais and respected audience. Today I am presenting one of the topic. Today I am presenting my topic in the International Pharmacological Conference, 55th Annual Conference of Indian Pharmacological Society, IPSCON 2025. So my topic is molecular docking and dynamic study of Spathodia campylorata phytochemical targeting anti-apoptic BCL2 family proteins. So these are So basically, I have selected this topic to just check the compound which is available in the Spathodia campylorata. Is it audible? Yes. Yes. Whether it shows its anti-apoptic activity in cancer cell or not. So basically, that BCL2 family, these are some anti-apoptic proteins which very helpful to prevent the cancer. So in my study, I have explored this Spathodia campylorata phytochemicals, basically the quercetin and oxalic acid. So methodology here I am using some ligands, caffeic acid, quercetin, camphorol, ursolic acid, and these are the some targets, that is the BCL2 6O0K, BCLW 4K 5A, and MCL 6O 6G. So docking which very simple, that autodock vena, then MD simulation 100 nanosecond, GROMAC, and ADMT analysis by Swiss ADME. And in docking result, I found that ursolic acid is a minus 8.7 kilocalorie per mole, quercetin minus 8.5 kilocalorie mole, and these are the some amino acids which have interaction with, and these which compare with the abatoclax, which is one of the standard agent, which shows the good molecular docking result with the particular molecule. And these are the some 2D and 3D views for the specific type of BCL2 600K. Then for ursolic acid, for MCL1, these are some hydrogen, hydrophobic, pi sigma, pi alkyl, then unfoldable donor, then conventional hydrogen bonds, then number of amino acids, then MCL, 2D, 3D for ursolic acid, then BCLW, 4K, 5A docking pose with quercetin, same for ursolic acid. And these are some interaction analysis. So here some active amino acids, some bond length, bond category, bond type, and docking score. So this docking score, it will indicate that most of the interaction with that particular hydrophobic or what we call as a electrostatic, that cavity is available, so there is a more chances of binding of that protein molecule with that particular cavity. So it will shows good interaction with that particular amino acids. So these are the MCL1 606G, and these are the some types of amino acids, then bond category and bond type, and docking score. So it is a ongoing study. So the next part is remaining basically on the animal studies also remaining for this. So molecular dynamics study, it will indicates that basically that whether the molecule is stable or not. By 100 nanoseconds simulation, that stable complexes are staggered there, and they will show the good stability at that case. Then RMSD, so regression mean square deviation, in that 2 angstrom structural stability is there, and stable RG, rigidness, and low RMSF value, that is a regression molecular SF values. Then ADMET analysis, so in that quercetin and camphorol, which shows the high J absorption and good viability. Ursolic acid also shows the strong viability and low toxicity, and all compounds shows the drug-like profile. And basically this compound occupies these BH3 binding grooves basically, and this disrupt the BCL2 Bax interaction, and that promotes the apoptosis. And it is also basically supported by the literature evidences. And thank you. So basically these are molecular docking study, and actually I'm pharmacologist. To assess the stability using molecular dynamics simulation. So that one is remaining, some part of it. Just I have done that basically docking study in that case. So in intrinsic pathway, there is this type of family. Then intrinsic and extrinsic, that comes together, that form the caspase pathway, and then caspase which promote it, which inhibit the proapoptic pathway. That BCL2 level should be goes down, because these are the types of available on the mitochondrial cytochrome C. Through there they are working basically. BCL expression should go down, sir. In case of BCL2, these are the family BCL2 family proteins. These are BCL1, BCLW, and MCL. These are the proteins under the BCL.
Our next presenter is Ravindra Jarg from Bharati Vidyapit College of Pharmacy, Kolhapur.
Good evening. I am Ravindra Jarag, presenting my work, Formulation and In Vitro In Vivo Screening of Anti-Cancer Potentials of Bioactive Loaded Cubosomes. Bioactive found in the medicinal plants, including oleanic acids and so on, flavonoids, polyphenolic compounds, and many more, which will inhibit the cell growth. Cubosomes will gain the utility and acceptance as a novel drug delivery in the diseases like cancer. Main objective is rather than taking extraction of drugs, directly ready-made bioactive we have procured, and we have prepared the cubosomes from that. So it will reduce the particle size and it will increase the solubility as well as it will increase the bioavailability. Aim is to develop NDDS formulation, that is a phytomedicine, develop bioactive loaded cubosomes, and to improve the efficacy of preparation and characterization, target selectivity, and controlling release profile of that loaded bioactive. Bardoxolone methyl cubosomes with porous nanostructure has been potential drug delivery. With the help of microfluidizer, we have prepared the cubosomes, and in vitro cell line study with the B16F10 cell line. We have performed that, and zeta potential, particle size, entrapment efficiency, these are the different characterization tests we have performed. For animal study, we have approved the protocol from IISc Bharati Vidyapit College of Pharmacy, Kolhapur. With the box Bankum design, we have prepared these cubosomes. First, GMO and Poloxamer 407. These are the two components. They have taken 9:1 in the ratio and melted in the hot water bath. Then added the drug of 3 to 5%. Then stir well, hydrating mixtures gradually with the addition of water with the Vortex mixer. Then the cubic phase of gel formation was formed 24 to 48 hours at room temperature. Then fragmentation is done with the crude dispersion by adding the water. Then with the help of probe sonicate for 25 degrees centigrade for 5 minutes. Then with the help of microfluidizer, high pressure homogenization pass by the cycle 20,000 psi pressure at 25 degree temperature. And then it was passed through the store at room temperature. This is the methodology we have used in our laboratory, and the powder form of the cubosomes were developed. Then developed cubosomes, they are evaluated for particle size, zeta potential, and entrapment efficiency. With the help of box Bankum design, we have developed 13 batches. Out of that, batch number 8 is optimized batch. Even though the size is around 179, but entrapment efficiency for this particular batch is more. That's why this particular optimized batch is further taken for the evaluation. These are the results of particle size near about 160 nanometer, and cubic phase, all particles line in the one line. Zeta potentials in the negative, which shows the stability of the formulation. entrapment efficiency is good. Then MTT assay is performed with the B16F10 human melanoma cell line. With the increasing concentrations, cell viability is decreased and IC50 value is around 56.96 microgram per ml. As far as carcinogenesis is concerned, we have used DMBA, crotonal induced skin cancer model, in which 4 groups we have prepared: negative control, positive control with the standard 5-fluorouracil. Then thickening of epidermis, invasion of epidermal cells and fibroblasts they have measured. 1 month study is performed. Conclusion: bardoxolone methyl compound has better anti-cancer potential. It has shown promising preclinical cancer studies by inhibiting cancer cell growth through the mechanisms like arresting the cell cycle, suppressing epithelial transitions. Novel, safe, effective and stable cubosomes with the improved bioavailability is used to adjuvant to prevent in cancer. Our next target is, along with this, we are again mixing 2 to 3 bioactive together, and we are developing phytomedicine for that. We will add the borneal is one of the constituent which will enhance the permeation. So by oral route also and by external also, both at a time this particular natural compound we can give, and if we are combining 3 to 4 bioactive together, that can be called as a phytopharmaceutical. So that is our final goal. Thank you. Tumor size.
No, where the cancer cell growth actually.
So
when you are mentioning, sir, actually apoptosis.
Yeah.
See,
yeah.
By inducing apoptosis, which parameter indicate there is a apoptosis?
Yeah.
No, because that's why whatever
Yes.
we are concluding,
Yes.
because they know actually like as such arresting of the cell
Yeah.
cycle and all.
Yeah.
Whatever our results will be based on that, we are going to
Okay.
conclude actually.
Okay.
That is fine. Otherwise, that's a hypothesis actually what you
Okay.
are going to indicate over there.
It's about the same third conclusion: novel, safe, effective, stable.
Stable.
So for the safe, we have not carried out any efficacy study.
A stability study.
No, I'm talking about the safe.
Safety study. Did you?
So conclusion exactly should be
Acute,
on the basis
acute
of
oral,
parameters.
acute oral toxicity studies also perform to calculate the LD50.
Which is LD50 nowadays, you know, which LD50 nowadays?
No. For acute toxicity study. As per OECD guideline 423, we have performed.
So nowadays everyone do this MTD.
Yeah.
Okay. MTD. Maximum tolerated
Yeah,
dose.
it's a single word, like in it's a huge meaning.
Okay. Okay.
So these are all exaggerated conclusions.
Overclaim actually.
Overclaim,
So
exaggerate.
you cannot say like may have better actually.
Huh.
Because when you are proving actually, how you
Okay,
can say it's a better
okay,
than actually.
okay.
Unless until you have some comparative study with your formulation actually.
Yeah.
And it looks
Our next
more-
target is we are using biomarkers also as far as induction. So that is my latter part. Okay.
Yeah, looks like more
Okay, sir.
novel drug delivery
Yes, sir,
system
yes,
work,
yes,
not a use of
Yes,
indigenous medicine
Yes,
and
yes.
for treatment.
Okay, sir.
Thank you.
Thank you, sir. Okay. Okay. Okay, sir. Thank you.
Okay, so good afternoon, everyone. My name is Chandan Chauhan, and today's I'm going to present my research work that is entitled that Senegin elevates cerebral ischemia reperfusion injury by suppressing inflammatory and cell death pathways. So that stroke is one of the second leading cause of death worldwide. In India, while I am presenting here in India, every minute some stroke death is happening, and within every 4 minutes some death with stroke is occurring. So in case of stroke, we can call that time is brain, because 1.9 million of brain cells died every minute. So while you're talking about the event of ischemic stroke, that excitotoxicity, oxidative stress, inflammation, apoptosis is there. However, that inflammation and apoptosis takes from hours to days. So targeting that inflammation and apoptosis could be a promising approach for the treatment of stroke. So this Sig-assisting signaling is one of the emerging targets that have shown some potential effect against stroke. Targeting this pathway shows some potential effect in stroke. So from this hypothesis, we design an experimental design. So in vivo, we did medial cerebral artery occlusion, and for in vitro, we did OGDR cell model. And we choose that Senegin, which is one of the natural compound from polyglotte anifolia. And we did in vivo that TTC staining histopathological and molecular studies. However, in vitro, we did inflammatory markers and Sig-assisting pathway analysis. So that Senegin elevate in MCO-induced IR neurological defects, which we did. For this, we did that modified neurological severity score, force, grip strength, which we determined in force, then distance, travel, ambulatory time, in which we found that Senegin treatments elevate MCO IR-induced neurological defects. Furthermore, after 24 hours, we estimate infarct volume and brain edema, and we shown that Senegin, that 10 mg per kg with significant decrease in infarct volume. Furthermore, we seen that microglial activation and inflammatory markers, and we found that Senegin mitigate MCO-induced microglial activation and inflammation. Further, we did in vitro in OGDR models these all inflammatory markers like IVA, INOS, and COX-2, and we found that Senegin, it's further decrease in expression of IVA, INOS, and COX-2. So goes to that further we did that neuroinflammation is related to sting IRF3 pathways. So further we did that in MCO model. Further, we found that Senegin is reduced in expression of phospho-IRF3, phospho-TVK, and phospho-TVK1. In vitro studies also found that there is a decrease in expression of these phospho-IRF3, phospho-TVK1, and downstream, that is interferon beta. In this IF image, that we can see that it's further decrease the translocation of phospho-IRF3, nuclear translocation of phospho-IRF3. So this IRF3 pathways is for downstream leads to cell death, that is pyroptosis and apoptosis. For this, we did for pyroptosis, we did that pyroptosis markers, that NLRP3 and that's clipped caspase 1, and we found that furthermore, we did that docking studies, and these docking studies show that Senegin decrease in. So in conclusion, our study found that Senegin decrease in IRF3 pathway. Thank you. Yes.
What was the time of administration of your agent?
We did MCO for 2 hours followed by reperfusion.
When you administer your drug?
During the reperfusion phase and after 12 hours of.
Okay. So can you name actually a few drugs which have actually been approved for the stroke?
Yes, sir. Sovatiltide is.
Sovatiltide. Okay.
Yes, sir. In India, I think it is in for.
What is the mechanism?
It's an endothelin receptor.
Okay, acting
yes.
on the endothelin.
Yes.
Okay, fine actually. Can you show your this cerebral infarction? Okay. So when you are showing, I think, neurological deficit actually, okay, and in comparison to your this MCU occlusion-induced infarction, what kind of correlation did you find actually? Whether neurological function were correlated with the infarction actually, degree of infarction?
Actually, sir, that neurological defects, we did modify neurological scope, and 3 time point we consider. We did initially 4 hour, 12 hour, and 24 hours. So what we seen after that 24 hour, that neurological neurological severity was decreases.
Okay, next slide. Yes. Yeah. Okay. So now actually what you postulating actually, the role of mainly this particular signaling pathway working through anti-inflammatory mechanism or what?
Actually, this pathway is acting through anti-inflammatory. What has happened when there is an ischemic stroke, in core region, sudden cell death is there in form of necrosis. So there is various dams was released. One of the dams is DNA, which bind to CGAS, and then this inflammatory that CGAS histone pathways get activated. And this recent further various studies suggest that this signaling is leads to pyroptosis, apoptosis, ferroptosis, and various kind of cell death is there is relation to this signaling.
Okay, so whatever the cellular structural protection or improvement you showed to the various parameters, whether it is translated into a neurobehavioral improvement?
Yes, sir. Neurobehavior that we did initially we did neurobehavior. After that, we did that molecular parameters.
So what is the translation?
We found that after 24 hours, the treatment with senazine, that increase in neurobehavior parameters. That in modified neurological severity score, what we found that is various 18 parameters is there in modified neurological severity scores. So we check that that grip strength is there. Then in walking, yes, 18 parameters.
There was a significant improvement you have observed.
Yes, sir.
Okay, good.
Okay.
Thank you.
Our next presenter is Balwinder Singh from Central University of Haryana, Mahendragarh.
Good afternoon, everyone. Myself, Balwinder Singh, and I'm currently pursuing a PhD from Central University of Haryana. And this is my master project. That is, the title is Neuroprotective Activity of Plagorim inguinans that against the aluminum chloride-induced Alzheimer's disease in a Vista rat. So no. So I start with the introduction of a disease. The Alzheimer's disease is also known as a progressive and irreversible. Alzheimer's disease is also known as the progressive and irreversible neurodegeneration, that lead to the memory loss and cognitive decline. So these are the pathological markers that is such as amyloid beta and neurofibril tangles and synaptic close, and such as mainly the target of the hippocampus and medial temporal lobe and cortex. So after that, these are some hypotheses for the AD. Mainly I target to the acetylcholine acid hypothesis. So there are some current therapeutics that lead to the only for the systematic curement. These are the listed. For the limitation, there are the temporarily symptomatic leave only, and do not stop disease progression. So the need for the new therapeutics The current drugs are not disease modifying, so the natural compounds have the antioxidant and anti-inflammatory and acetylcholine inhibitory potential. So if we in this study we choose the Plagorim inguinan was the investigated for the neuroprotective activity against the aluminum chloride induced Bistar rat. So these are the objective of this study. So firstly we found that this plant, and after that after that we go for the authentication and go for the preclinical quantitative and qualitative study, and then for the antioxidant study for this plant, and go for the find out the phytochemicals by using the GCMS analysis, and go for the molecular docking and ADME studies, and go for the in vivo to check the potential of cognitive deficient in the Vista rat. So after that we found that we estimate the antioxidant acetylcholine activity and anti-inflammatory markers in the brain rat. And after that and end of the study we found we study the histopathological study. So this is the plan of work that I also discussed. So this is the main plant, that is a picture of plant. So this is the preliminary quantitative and qualitative study that show the color, odor, and taste and other. And this is the qualitative studies that show the metabolites, that these are the present or not present. And after that, in this study, in this quantitative phytochemical study, the total phenolic content was found. This is the 309 mg of gallic acid per gram. We found that. And in the next slide, for estimation of tannin, we found that the 78.30 mg gallic acid per gram, and after that the flavonoids is also present in 297.44 mg of quercetin. After that, the estimation of antioxidant potential, we studied the DPPH and FRAP assay, and as you shown in the graph, the plant is shown as the 92.19% inhibition, and standard is the gallic acid shown as the 94.20% is inhibition, and also the IC50. And the FRAP assay, we increasing the concentration of both sample and standard, the reducing potential of also increase. So the identification of phytochemical, we study we use the GCMS, and this is the graph, and these are the 21 phytoconstituent that we found that. And after that, for the docking study, we use the 1-ACJ molecule, and we out of 21 we choose I show just these are the 5, and donepezil 4 as a standard, and these are the 3D structure for these 6. And after the in vivo study, the behavior parameter that shown the spontaneous locomotor activity. As for the spontaneous locomotor activity, we check every 7th day. For example, 7th and 14, and next is this protocol is a totally 21 days protocol. And as you see in this graph, the first day that locomotor activity is the same, but as the disease is progressing in a disease model, the locomotor activity is decreased, but as in a treatment and standard, the locomotor activity is better. In the other, we studied the EPM test. In this test, we found that the rat, how much time is retained in close arm and close arm and open arm. So we found that the disease model is generally mainly retained in a close arm, and as a treatment, and the standard model is retained in a open arm. So in a MBM model is a Morris water maze. As you saw in this model, we did Morris water maze for the 4 days. It was just 16, 17, and 19. As you see in the figure that the latency period of disease model is increased, but the treatment and the standard is decreased by the day by day. And these are the picture that captured by the automated anime software. And after that, we found that the estimation of inflammatory marker, that is interleukin 1 beta and TNF alpha and acetylcholine activity. So we in this study, the level of interleukin beta and TNF alpha and acetylcholine is increased, but that decrease significantly in treatment and other. So in a measurement of oxidative stress marker, the MDA and GSH and nitrite, the level of MDA and nitrite is increased in this, but decrease in this. But GCH in the disease model decrease level, and another model there is a treatment and standard is increase. So these after that we found that the histopathological studies. These are the histopathological pictures for the control group and then disease model. And the treatment, that is 200 mg is the best for, and this is the donipezil histopathological. And in conclusion, I include the EEPI is a 200 is a most effective than other treatments. Thank you, sir.
High failure rate due to adverse side effects.
Laptop study.
Yes, it's a general
It's a
statement
lab study
actually.
for a laptop study.
It's a general statement actually. No? That's
Okay.
take care. I think take care actually. All those things.
I mean, who is that we will improve in the future presentation.
Yes, yes.
Okay.
We extend our heartfelt gratitude to our esteemed chair, Dr. S.D. Sinha. Now I request the Dr. Manish Jain to kindly felicitate our chair. Please come. Sir, please come on the stage. Our next presenter is Dr. Nandini Dubey from AIIMS, New Delhi.
I'm going to present my work titled Evaluation of Vinpocetine, a novel compound along with enalapril in experimental model of diabetic cardiomyopathy, focusing on phosphodiesterase, TGF-beta and SMAD pathway. So when we talk about diabetes, it is rapidly increasing worldwide, and India is expected to have a maximum number of diabetic patients having secondary complications. One such major complication is diabetic cardiomyopathy, and this diabetic cardiomyopathy mainly develops due to oxidative stress, inflammation and fibrosis. So when diabetes develops, and when high glucose is given, it increases phosphodiesterase 1, which further activates TGF-beta and SMAD pathway, causing oxidative stress and inflammation, as well as cardiac fibrosis, which collectively leads to cardiomyopathy. So we hypothesize that this phosphodiesterase inhibitor, which is vinpocetine, a natural alkaloid, inhibits diabetic cardiomyopathy, and also it inhibits phosphodiesterase 1 and TGF-beta, as well as these downstream damaging events. Therefore, vinpocetine exerts its protective effect by attenuating cardiac injury markers, oxidative stress, and inflammation through phosphodiesterase, TGF-beta, and SMAD activation, and preventing myocardial fibrosis. So there are total 8 experimental groups used in this study, in which different doses of vinpocetine was used. The doses were 10 mg per kg, 20 mg per kg, and 40 mg per kg. And the enalapril dose was 10 mg per kg. And the last group is a combination group in which vinpocetine and enalapril was given. So to induce diabetic cardiomyopathy, we have given a high-fat diet for 2 weeks to the rats. And at starting of 3rd week, we have administered streptozotocin of dose 35 mg per kg, and then continued high-fat diet for 9 weeks. And vinpocetine and enalapril was given for 8 weeks. After 11 weeks, all the parameters were taken, except blood glucose level, which was taken at after 3rd week and at starting of this experiment. Coming to the result part, in body weight, heart weight, and in heart weight index, there was no significant difference was found among the groups. In blood glucose level, at baseline and after 1 week of giving streptozotocin, there was no significant difference was found among the groups. But after 1 week, in fasting blood sugar and in fasting blood sugar and postprandial blood sugar, we can see increase in diabetic groups. And when we compared it with vinpocetine alone and combination group, we can see clearly that fasting blood sugar and postprandial blood sugar was decreased. In echocardiography, cardiac output and ejection fraction was improved in treatment groups. And left ventricular pressure, dP by dt maximum and dP by dt minimum was augmented in vinpocetine alone and combination groups. And these are the images of echocardiography which was done during the experiment. In histology, when mesenteric staining was done, we can see that diameter of cardiomyocytes was increased in diabetic groups. And when we compared it with vinpocetine alone and combination group, the diameter of cardiomyocytes were decreased. And again, when we did Mason's trichome staining, we can see that there was increase in diabetic group. And when we compared it with vinpocetine alone and combination group, the total collagen area was decreased. In RT-PCR and Western blots, the mRNA and protein expressions of phosphodiesterase 1, TGF-beta, and SMAD was increased in diabetic groups. And when we compared it with vinpocetine alone and combination group, the mRNA and protein expressions of phosphodiesterase 1, TGF-beta, and SMAD were decreased. In inflammatory markers, that is TNF-alpha and interleukin-6, the levels were decreased in both. And in myocardial enzymes, like lactose dehydrogenase, CKMB, and aspartate aminotransferase, the levels were improved in vinpocetine alone and combination group. When oxidative stress was done, we can see here that glutathione, superoxide dismutase, and catalase were increased in vinpocetine alone and combination group. And when we compared it with malondialdehyde concentration, the levels were decreased. So we summarize that vinpocetine significantly reduced oxidative stress markers, lowered pro-inflammatory cytokines, also improved ventricular pressure, ejection fraction, and reduced myocardial fibrosis. We saw that the diabetic heart showed elevated phosphodiesterase 1, TGF-beta, and phosphorylated SMAD expression. Also, combination of vinpocetine alone and enalapril synergistically improved glucose levels, cardiac function, oxidative stress, and fibrosis individually. So we, for the first time, reported that vinpocetine exerts its protective effect through the phosphodiesterase 1, TGF-beta, and SMAD pathway in an experimental model of diabetic cardiomyopathy. Thank you. Which slide, sir? Oh, yes. Yes. In echocardiography,
Yeah.
I have done cardiac output and ejection fraction, sir.
So ejection fraction improvement in which way? Let's say a person is having ejection fraction of 62%.
Okay.
If that is improved by now at 67%,
Okay.
and a person is having ejection fraction of 35%,
Okay.
and now the improvement is at 40%. In both the cases, the improvement is 5%.
Yes, sir.
Are the same?
If improvement has taken place from 35 to 45%, 40%, then this is not normal condition. The patient is still in pathogenic condition only. So we cannot say that the person is normal. Or
So if you look at the echoes you have presented there, most of them are normal echoes.
most of them are normal, yes, sir.
So
Because
improvement in normal over normal
yes.
makes no sense, number one. For that, you need to collaborate with anti-proBNP level or any other thing. That's number one. Number two, you have said it improves echocardiographic finding and myocardial fibrosis. What do you mean by myocardial fibrosis improvement?
Myocardial, if I'm talking about myocardial fibrosis, for example, TGF-beta, if TGF-beta is increased, it will lead to fibrosis.
Have you heard about a term called cardiac remodeling?
Yes, sir, cardiac remodeling.
What is that, and how does it collaborate with echocardiography?
Sir, cardiac...
If you answer that, the answer is there already.
Yes, sir.
If you answer it,
yes, sir.
the relationship between cardiac remodeling and echocardiographic finding, why your inference is self-contradictory, you will understand by yourself.
Sir, actually, if our heart is not working properly, that means, for example, fibrosis has taken place or fibroblast.
Is myocardial fibrosis a physiological process? Does it take normally in normal people, or is only a pathological
Yes,
process?
sir. Fibrosis takes place in normal condition also, but if it is increased much, then it is we can say that it is.
So again, there is a differentiation between improvement in physiological state and change in pathological state. So both of them are not the same.
Okay.
Thank you for the good presentation.
Okay. Thank you, sir.
Yeah, Nandini, good presentation. I have just two questions.
Yes.
How did you confirm whether it's a type 2 diabetes actually?
Sir, if there is insulin resistance or pancreatic
No,
beta
where is the
cells.
insulin resistance, insulin level?
Sir, actually, we have done fasting blood sugar and
No, fasting blood sugar is not a...
we have not done the parameters.
So that's why I think your model standardization has to have actually the parameter insulin resistance. Second, just general question being pharmacologist actually, the per se group.
Yes, sir.
I think in your study I did not find per se
Yes, sir,
group.
yes, sir.
So that you should incorporate in
Okay, sir.
future. Okay?
Okay.
Yeah, best. of luck.
Okay, thank you, sir.
A big round of applause for all presenters for their outstanding scientific contribution. Now I request two judges, please come on the stage and have a seat on the dais. We extend our heartfelt gratitude to our esteemed chair, Dr. Mukesh Nandave, for steering this session with their remarkable expertise. I now request Dr. Manish Jain kindly felicitate him. Dr. Payodi Dhar, please. Dr. S.S. Sharma. I'm just changing the slides. I don't know where they- Judges, please have a seat on the stage, please. Now I request to all the president, please come forward near the stage. We will have a photograph with you. Please don't go anywhere. We are starting to.
Good afternoon, everyone. We are starting with the next segment of the program with the symposia. Okay. Maybe they thought that there is a short break, but we are running out of time. We're starting right now. So we can call them.
Good afternoon, everyone. Distinguished. Shall I can start? Manish, sir. Fine, no issues. Okay, good afternoon, everyone, distinguished guests, respected faculty members, dear participants. Welcome to Symposia 7, which is themed as preclinical pharmacology, navigating translational challenges and ethical considerations. We are honored to have with us our esteemed chairs, Dr. Adipali Viranjanalu, Dr. Mahendra Bishnoi, and Dr. Rohit Bisht. We extend our sincere respect and gratitude to them for leading this important segment of today's scientific program. I'll be introducing our chairs. Dr. Adipali Viranjanalu is a highly accomplished pharmacologist with over 40 years of academic research and industrial experience. He has led major drug discovery programs, guided numerous PhD scholars, published extensively in cardiovascular and metabolic and neurological pharmacology. He's a recipient of multiple national awards and currently serves as the Director of Research and Professor of Pharmacology at Dr. D.Y. Patil, IPSR, Pune. Dr. Mahendra Bishnoi, it's my privilege to welcome Dr. Mahendra Bishnoi, Scientist E at National Agri-Food Biotechnology Institute, Mohali. Dr. Bishnoi is an accomplished researcher with expertise in nutrigenomics, obesity, metabolic disorders, and molecular nutrition. His scientific training includes prestigious postdoctoral work in US with over 55 high-impact publications in several DBT and DST-funded grants. He continues to be a leading voice in translational nutrition and metabolic research. We warmly welcome you, sir, as the chair for this session. And our third chair is Dr. Rohit Bisht, experienced pharmacologist with 2 decades of research experience in translational research, drug development, and integrative medicine. He has led to several national funded projects, mentored over 50 scholars, and advanced evidence-based phytopharmaceutical research for chronic disease. His work significantly contributes to India's modern pharmacology and innovation landscape. I welcome all our esteemed chairs, and now I request Dr. Bishnoi to introduce our first speaker, Dr. Adam Jason.
Hello.
Yeah. So, hello everyone. So as Sir has already told about the session, and first speaker for this session is Dr. Adam Gessing. He's a good friend of mine. It's my privilege to introduce him here. He is an endocrinologist and esteemed geriatric researcher with robust clinical and translational expertise. His academic journey spans significant contributions in thyroidology, geriatric medicine, and oncological endocrinology. He serves as an associate professor at the Medical University of Uz, where he leads Department of Endocrinology and Aging. His research encompasses aging processes, longevity, internal medicine, and metabolic disorders. So he has multiple research papers, prestigious national honors, including Rector's Special Prize and the Health Scientific Award. He holds several key leadership roles in endocrinology board and serves as associate editor for Frontiers in Endocrinology. So we warmly welcome you, Adam, here, and he will be talking about selected experimental animal models used in research on aging processes and their potential importance in pharmacotherapy. So stage is all yours, Adam. Yeah. And you have, I think, as we discussed, 15 minutes to 18 minutes, and then we follow it up with 2-3 minutes question. Yeah. Yeah. Thank you.
Dear chairmen, dear professors, dear doctors, dear participants of this amazing conference, first of all, I would like to say my huge, really huge thank you to the organizing committee for inviting me to participate in this conference. And believe me, it's really big honor for me to be here with you. And I start my presentation. One second. Okay, I start my presentation with the words of my, no, let's say with my guru in aging studies, Professor Andrew Bartke, from the Southern Illinois University School of Medicine, Springfield, Illinois, who concluded many, many years ago that the existence of single gene mutations that extend life creates unique, really unique opportunities for elucidating the mechanism of aging and identifying potential targets for interventions designed to slow down or delay this process. Oh, sorry. The first mutation, really the first mutation of a single gene which markedly increased the lifespan was described in 1988 by Friedman and Johnson in a microscopic worm C. elegans. The name of this gene was H1. This H1 functionally, if we take into account the homology of signaling pathways involved in the control of longevity different species, corresponds to PI3K in humans and mice. A lot of previous findings confirmed physiological role of the somatotrophic axis, growth hormone IGF-1, in the control of aging. Decreases in insulin growth factor 1, like signaling result in extended longevity in flies and worms. Also, decreases in pro-growth signaling result in life extension in yeast. And here are examples of dwarf and long-lived species. On the left, you can see it's a yeast SCH9 null mutants, which lives about 3 times longer than normal yeast. In the middle, you can such maybe information about short information about this gene. This gene SCH9 corresponds to AKT PKB in humans and mice and flies and worms. In the middle of this slide is an example of a dwarf female fly, Chico homozygous mutant female fly. This dwarf fly live about up to 50% as compared to normal flies. This gene, Chico, corresponds to RIAS in humans. On the right, you can see the example, one of the spectacular examples of dwarf mice. This mice is growth hormone receptor knockout mice. About this mice, I will tell you more a little later. So generally we can say that the most commonly in the aging studies we use these four kinds of species: yeasts, worms, flies, and mice. And now about mice. First description of dwarf mice was presented in 1929 by George Snell. This mutation, many years later, turned out that affects one of the transcription factors which is responsible in development of pituitary gland, PIT1, pituitary factor 1. PIT1 is responsible for development of three kinds of cells in anterior pituitary: somatotrophs, lactotrophs, and terotrophs. And primary effects of this mutation lead to failure of differentiation of somatotrophs, lactotrophs, and terotrophs, and finally is a lack of growth production, lack of prolactin production, and lack of TSH production. And maybe it is a surprise for you, that having such serious hormonal disturbances, these mice live much longer than normal mice. Longer about 45% as compared to wild-type mice. These Snell dwarf mice also are characterized by very reduced IGF-1 levels, reduced growth and adult body size, hypothyroidism, delayed puberty, and reduced plasma insulin and glucose. So, in other words, they are much more insulin sensitive. The second very similar kind of mice, very similar to Snell dwarf mice, was for the first time presented and described in the city Ames of Iowa in 1961. It is very similar situation. This mutation affects another transcription factors which is responsible for development of pituitary gland, prophet of pituitary factor 1, so-called is PROP1. PROP1 is responsible for required for somatotrophs, lactotrophs, and terotrophs determination. But effects are absolutely similar to Snell dwarf mice. Lack of growth hormone, lack of prolactin, lack of TSH. And increase in lifespan, 40 to 65% longer than normal mice. This is survival plot for Ames dwarf mice as compared to normal mice. The third kind of these mice, growth hormone receptor knockout mice. These mice, in contrast to Snell and Ames dwarf mice, were created in laboratory. In laboratory of Professor John Kopczyk in Ohio, and these mice, we can say, can constitute experimental mice model for Laron syndrome. As a reminder, Laron syndrome is a disease which is characterized by molecular defects of growth hormone receptor in majority of exons of growth hormone receptor gene. The name of this syndrome comes from a surname of Professor Zvi Laron from Tel Aviv University, who in 1966 for the first time described this type of dwarfism. And here is an example of child, of infant with Laron syndrome. Please look at this protruding forehead, sparse hair, and very small facial bones. Fortunately, it is a rare disease. It's a very rare disease. because of this similarities to Laron syndrome, these mice very often are also called like Laron dwarfs. What is primary effects? Sorry. Absence of growth hormone receptor, absence of growth hormone binding protein, and growth hormone resistance. And what else? Again, the same situation. Very, very reduced IGF-1 production in these mice. Delayed puberty, reduced growth and adult body size, reduced plasma insulin with reduced, sometimes normal glucose level. And again, enhanced insulin sensitivity. What else? Lower incidence and delayed onset of fatal neoplastic diseases. Improved oxidative stress resistance. Reduced generation of reactive oxygen species. And these mice also are resistant to cognitive decline. It's very, very interesting. Percent increase in mean lifespan, 40 to 55% as compared to normal mice. Survival plot for Laron dwarfs mice. And let me say that I also have some small contribution to the characterization of these mice. During my stay in US, I conducted research of these mice, and I demonstrated that these mice also are characterized by decreased gene expression and protein levels of pro-apoptotic factors in skeletal muscles and kidneys, and also these mice are characterized by increased gene expression of key regulators of mitochondrial biogenesis in the kidneys, hearts, and skeletal muscles, as well as increased renal protein levels of these regulators. This is like short summary of my detail of my results. For mitochondrial biogenesis and for apoptosis. I think it is worthy underlining that growth hormone receptor knockout mice are only recessive homozygous, because heterozygous and dominant homozygous are of a normal size. This fourth mice on the right, it is so-called double mutant, dwarf KO. We created also in US such another kind of experimental dwarf mice, dwarf KO, by crossing Laron dwarfs and Ames dwarfs. These mice also are, you see, a little smaller than dwarf and KO mice, but what is interesting, doesn't live longer. Almost 10 years ago, Professor Zvi Laron and his group published such paper like you see here about signaling pathways which can be involved in cancer protection in Laron syndrome. And this is examples of this changes in expression of genes related, for example, to cell adhesion, to cell migration, to apoptosis, to metabolic pathways, to cancer, etc. The next very important paper, 2017, Professor Bartki and Justin Darcy. They showed the proposed mechanism for extended longevity in growth deficient, Ames SNELF, and growth resistant, growth hormone receptor knockout mice. I would like to pay attention for a few of these, like increased antioxidant enzyme activity, decreased RAS production, decreased oxidative damage to macromolecules, resistance to cytotoxic, metabolic and oxidative stressors, decreased chronic low-grade inflammation, decreased circulating IGF-1 and mTOR signaling, and also shift from pro-inflammatory cytokines to anti-inflammatory cytokines. Adipokine is an example of such anti-inflammatory cytokines. By the way, adiponectin is also considered beneficial adipokine, and among others can improve insulin sensitivity and reduces atherosclerosis. Adiponectin levels adiponectin level is increased in these dwarf mice as compared to normal mice, but in another, like contrast model of mice, growth hormone transgenic mice which overproduce growth hormone, the level of this adiponectin is decreased. Generally, we must say that this growth hormone transgenic mice live shorter than normal mice, and can constitute like just an animal model for acromegaly in humans. Like summary, you see these differences in sizes of these mice. This slide shows again these changes in Amesdorf mice, in KO mice compared to normal mice, and I think one should emphasize that these very reduced IGF-1 levels, occur independently on growth hormone in paracrine or autocrine manner, because this is a main metabolic pathways showing the mechanism of action of growth hormone by IGF-1 directly and independently on growth factor. So, like a small summary for this. Decreased growth hormone signaling leads to increased lifespan via different mechanisms. You see, very low IGF-1 levels, very low insulin secretion, also increased adiponectin level, increased insulin sensitivity, increased activities of antioxidant enzymes. This is a feature of these dwarf mice and absolutely not beneficial features of growth hormone transgenic mice. So, general conclusion for this observation that decreased somatotrophic signaling is among the most important mechanisms associated with extended longevity. It's some, like fun fact. What is the oldest mouse in the world? The oldest mouse in the world is growth hormone receptor male mouse, and this mice lived almost 5 years. The average is just 2 to 3 years, almost 5 years. And for this mice, Professor Andrew Bartke was awarded and prized by Methuselah Foundation. So such conclusion, do you agree with it? Your opinion. Now it is my opinion. These features of dwarf mutant mice also resembles findings in normal animals, subjected to calorie restriction. Calorie restriction is a well-known intervention which has been shown to delay aging and increase lifespan. Of course, by many mechanisms. For example, via changes in levels of sirtuins, leading generally to increased DNA repair, increased mitochondrial biogenesis, increased genome integrity, etc., etc. CR also, calorie restriction also, increases lifespan in normal mice and Amesdorf mice. And also, CR improves insulin sensitivity in normal and Amesdorf mice. Visceral fat removal, it is the second one, very well known experimental intervention for increasing lifespan. Of course, we know visceral obesity leads to insulin resistance, decreased insulin sensitivity, metabolic syndrome, etc., etc. So we must be careful. And visceral fat removal has been reported to improve insulin signaling in normal mice and rats and extend longevity in rats. The next thing, what may be some kind of surprise for you. Okay, now KO mice. Dwarfs, so is decreased body weight. So it is as expected in males, in females. But if we one more tell about insulin sensitivity, increased insulin sensitivity in these mice, we must also remember that completely unexpectedly, being insulin sensitive, these mice are obese. These mice are characterized by obesity. And this obesity also is associated with, general fat tissue. I show you in a moment. Oh, this is absolute fat mass. In mice, in female situation, in aged mice is a little opposite. But this lower part of the slide, percent fat mass, relative fat mass in relation to body weight, no doubt. These mice are absolutely obese, being insulin sensitive. Visceral fat and information about also increased rate of subcutaneous fat in relation to visceral white adipose tissue. Look at this. In males, absolutely much more subcutaneous, and females is the same situation. And another thing which may surprise you, visceral fat removal and sham operation. Just as a reminder, sham operation control procedure in which all the operations employed in a surgical technique are imitated with the exception of the experimental. And look, in normal mice, visceral fat removal, okay, improves insulin sensitivity. We can expect it. We can expect it. But look at the situation in this scale mice. After removal of this visceral fat, bad, yes, bad fat, insulin sensitivity decreases. We observe tendency for insulin resistance. Completely opposite situation. And a lot of experiments, confirm this observation. So, conclusion, that the absence of growth hormone signaling, the secretory activity of visceral fat is profoundly changed and unexpectedly promotes enhanced insulin sensitivity. Last year we published such results of our studies in Amesdorf mice. In this studies we analyzed the gene expression related to lipid, glucose metabolism, insulin pathways, inflammation, thermoregulation, etc. And these results suggest that longevity phenotype in Amesdorf also, besides known mechanism, also may involve epigenetic reprogramming. Maybe it is also very important for this in this context, for this increased lifespan of these mice. What about cellular senescence? Cellular senescence is a fundamental mechanism in aging marked by irreversible growth arrest and diverse functional changes.
So you have 1 more minute to conclude.
1 minute. Oh, wow. Okay, so I will be fast.
So it should
okay,
be 10.
and very important feature for this cellular senescence is SASP, senescence-associated secretory phenotype. Of course, this SASP characterized by many changes. This is examples of these changes. So I will be fast, but I think this information is crucial. Because these factors have a dual nature. On the one hand, can be beneficial in short-term physiological contexts, such promoting tissue repair, halting the proliferation of precancerous cells. On the other hand, the long-term persistence could disrupt tissue homeostasis, impairs stem cell function, and promotes chronic inflammation and fibrosis. And hopefully, we have 2 major groups of drugs which be used in the treatment in aging medicine: senolytics and senomorphics. Senolytics selectively induce apoptosis, but senomorphics suppress the harmful effects of the CACP without killing the cells. So I will be fast. Examples, just for final part of my presentation. Some examples of senolytics like dasatinib. Dasatinib belongs to tyrosine kinase inhibitors. And of course also flavonoid polyphenols like quercetin and fisetin. This is a food where fisetin and quercetin can be found. This is another kind of our studies with use of dasatinib and quercetin, and really in the studies we showed that this combination can decrease markers of inflammation, markers of senescence, and markers of senescent-associated secretory phenotype, and also change the microbiome. This ratio, Firmicutes to Bacteroidetes. We know that high Firmicutes to Bacteroidetes is often associated with obesity, and in these results, in our studies, we showed this red horizontal columns is a change into increased number of Bacteroidetes as compared to Firmicutes.
Maybe you can conclude, Dr.
Yes,
Adams.
my last my last information, or just conclusion, maybe conclusion. So I would like to leave you with such a question, fundamental question. Is really this a future of medicine, senolytics and sonomorphics, especially, of course, in elderly people, elderly patients, in geriatric medicine. Who knows? The time will tell for this, about these problems. Thank you very much for your attention. Sorry.
Okay. Thank you, Dr. Adams,
thank you
for your lucid presentation. Sorry, we could not give more than this much time, but I'm sure those who are working on the preclinical pharmacological level by using different animal models, today we know how to choose a particular animal model for various disorders. Of course, he has talked about more on metabolic disorder side, but having said that, mice in a different situations, various physiological differences in the species, it's over. In fact, skid mouse is another at an area where we can. So same way, CNS disorders. So one can take, and today I just, before I leave it to the audience for one more question, I just want to ask you, in the emerging situation of artificial intelligence, can we take the help of choosing the particular animal model for a particular disorder?
Thank you for your question, but it's really hard to answer to this question because each of these models can some, specific features. So, of course, we have a lot of such animal models. I have no time, so
yeah, that's what.
For example, little mice, or so-called Philco mice. It is a deletion of gene specific to one tissue.
Exactly.
Fat tissue, for example.
Thank you. Please go ahead.
Excellent talk. I have a question regarding one or two couple of questions. If you knock down, silent the gene in the normal mice, the growth hormone, GS, can you recapitulate those findings? If you silent in the normal wild type mouse, okay, can you, using shRNA or something, can you get those response, what you're getting in the knockout mice, the GS receptor knockout mice?
Can we produce the same response even after?
If I silent this in a normal mice at embryonic stage or in embryo, can you?
Okay. Maybe I can answer you for in such way. Because in endocrinology we have problems with pituitary work.
In the paucity of time, we should move on to the next speaker. Thank you very much. I think the second speaker, that is Ratnayake.
Thank you very much, Dr. Jising, for your enlightening and scientific reasons rich presentation. Your insights on aging models and their translational value greatly deepen our understanding on the pharmacotherapeutic advancements. Now, Dr. Vishnu to introduce our second esteemed speaker, Dr. Kalpani.
Yeah, so second speaker is Dr. Ratnayake. She is BSc in Human Biology and PhD in Food and Nutrition with a specialized training in animal sciences and product development. Her research focuses on herbal cosmetics, traditional medicine, and preclinical evaluation of chronic diseases. She is a passionate advocate of ethical science. She has served as president of SAAT Sri Lanka and SLALAS and currently holds many leadership roles including General Secretary, OWSD Sri Lanka and Joint Secretary of the College of Biochemists. So we welcome you, ma'am, and we look forward to hearing Swimming Towards Ethical Innovations, the role of zebrafish in replacing traditional animal models of dermatology. The floor is all yours, and we hope for.
Good evening, all of you, and thank you very much for your kind introduction. And my talk is based on swimming towards ethical innovation. work. Then when we get the models of dermatology research, there are different models. In earlier there are traditional models such as the animal model, and nowadays we know there are a lot of alternatives such as in vitro models like the keratinocyte cell culture, then the ex vivo models like the human skin explants and skin tissue slices, then the computational and in silico models, and also the clinical research and the high throughput or a screening models. And my topic is the swimming towards ethical innovation, the role of zebrafish in replacing traditional animal models in dermatology. So here I would mainly like to discuss about different animal models that we can use for the dermatology research, and their limitation and how this zebrafish model can replace these models. So when we get the mice model, we can see there are a number of past research which are based on this mouse model, and we can use mouse in research related to different disease conditions like the psoriasis, eczema, and also for the skin cancer likewise. And if I say why we can select this mouse model, they have well characterized genome, and also they have availability of transgenics and the knockout strains, and also similar immune system to human. However, when we get this mice model, it's not 100% good model because there are certain limitations. Like when you get the mouse skin, the mouse skin is much thinner, and also it heals primarily by contraction, not like in the human which heal by re-epithelialization. And also when you get the mouse skin, there are differences in hair density, then the sweat gland, and also the lipid composition. In other than to that, there are ethical concerns related to these models because when we use these models in the chronic disease conditions, they have long-term stress, and also we need to euthanize these animals at the end points. And also there is ethical pressure to reduce mammalian use for this research. Then when we get the rat model also already used for the toxicology and the wound healing studies, and also some pharmacokinetic studies. When we are talking about the advantages, their large size allows easier sampling, and also they have similar metabolic processes to human. But here you can see that these models also have some limitations, like the skin physiology differs significantly as in the mice. It's thinner, and also there are limited melanocytes and limited genetic tools compared to mice. In other than to that, in here also there is ethical concerns, and also when we use these animals for the wound or burning models, then it makes a very pain and the distress to animal. And when we get the guinea pig model, in the research papers we can found that guinea pig is used to check the contact dermatitis, allergic reactions, and the phototoxicity studies. And why we can select this model? Because their skin and immune response closer to human in allergic reaction, and also the standardized for sensitization and irritation testing. However, they have limited genetic tools, and also these studies are expensive and more difficult to handle. In other than to that, when we are talking about the ethical concern, it makes discomfort from irritant testing to these animals, and also we need to euthanize in the post-experimental stages. Then when zebrafish that they have rapid development. Then the high fertility and the optical clarity, and the zebrafish reproduce in a large numbers and develop externally, which allows direct manipulation and observation. Then the embryo and the larvae are transparent and allowing live imaging of cells, tissues and disease processes in vivo without invasive access. And also, when we get the zebrafish model, there is a cost effectiveness and throughout scalability, and housing, breeding and experimental manipulation of zebrafish are far less resource intensive compared to mammalian model. And their small size, the fast cycle and external development make them highly amenable to medium to high throughput screening of compound, ideal especially in dermatocosmetic research. And also there are ethical advantage. This model is alignment with 3Rs and the reduced mammalian use. Because zebrafish are smaller vertebrates, many institutions and the regulators consider them lower on complexity than mammals. Likewise, because of these reasons that we can identify the zebrafish as a, sorry? Okay, so good model for dermatology research, and here you can see some of the applications that we can use the zebrafish as a model. So we can use it for the pigmentation and the depigmenting agent screening, as it has the melanocytes and the melanin production mechanism similar to human. And then it's good for the heritable skin disease diagnosis. And also we can use the zebrafish for the skin cancer tumor as a model, and the wound healing, inflammation, and also for the toxicology and screening for irritants. And however, in the zebrafish model also we can see some limitations like in other animal model, because when we get the zebrafish, they don't have stratified epidermis and the keratinized layers as human, and also they don't have no hair follicles and the sebaceous gland. And and also when we get the zebrafish, there are some immune system differences, and also the physiological and the environmental differences, because they are in the aquatic environment. And also they have mechanical and barrier functional differences, and the limited transmissibility for some diseases. So that's mean, although we can use the zebrafish as a model for dermatology studies, it is not a good model for each and every dermatology research. There are some research that we can use the zebrafish as a good model, and here you can see the models that we conditions that we cannot use zebrafish as a good model. So we cannot use zebrafish for the hair related disorders, as they lack of follicle and the sebaceous gland, and other disorders that shown in this slide. So I am not going to read all these because of the limited time. However, when we get the zebrafish, it is an excellent model for live imaging research, which are important for inflammation and the wound healing, then the melanocytes research, then the high throughput drug screen, and the basic epidermal developmental study. And however, here you can see although we can see some limitation in the zebrafish model, we can use this zebrafish as a good model to replace the traditional model that we use animals to adhere to this 3R concept, and it's important to reduce some ethical issues based on these large animals. So as a conclusion, I can say that the zebrafish can use as an ideal model, not for all dermatology research, but some selected models as I mentioned on my slides. So thank you very much for listening. especially the replacement. In the OECD, the zebrafish egg embryo assay that we can use up to 72 hours because of the lifespan. Okay, thank you.
Thank you, Doctor. Thank you for your thought-provoking and forward-looking presentation. Your emphasis on ethical innovation and evolving role of zebrafish model highlights an important shift in preclinical research. Now I request Dr. Bishnoi to introduce our third.
So, sir, we look forward to your talk, and which is on practical applications of AI, which is really nowadays a very burning topic in pharmacology. Sir, please.
Thank you, sir. Can someone put my? Thank you, sir. Can someone put my PPT here? Is it already there on desktop? Okay. So a very good evening to all of you. Thank you, sir. I am Dr. Dharmendra Ahuja, Principal Mentor, Bureau for Health and Education, Experimental Pharmacology Software, Listed Mentor for Change with Niti Aayog, Government of India, Pattern Member, Indian Pharmaceutical Association. So the topic as practical application of AI in pharmacology. So before going further, we will be seeing in this sequence what is virtual experimentation in before that we will see like what is AI, then we will see what is virtual experimentation in pharmacology, what are the techniques, the software available from Bureau for Health and Education, how does it helps, advantages. So first of all, that artificial intelligence, I'll not take more than 15 minutes, but as students are sitting also here, sir. So like artificial intelligence is something everyone is using, but very few people are aware of it, like what exactly it is. It is nothing but see, earlier calculators were used. Calculators for calculation, and before calculator abacus principles were used, and then calculators came, and after that softwares came. Now this is the next level of software development, that is AI. Means in calculator you will write 2 plus 2 is equal to 4. Software means in Google you will write whatever term, experimental pharmacology, you will get what are the options available for experimental pharmacology. And AI is ChatGPT, for example. There you will ask them some logical question also, like which is the best software available at present for pharmacology experimentation. So they will collect the knowledge, but they will apply some artificial intelligence, correct information. So that is the next level of software development. So before going into application of AI, we should be aware of what is AI. Simply calculator, Google and ChatGPT. ChatGPT is the example of AI. There you don't ask, you simply do in ChatGPT you will not write artificial intelligence or sorry experimental pharmacology software. There you will write which is the best experimental pharmacology software. So that will give you particular result. So similarly nowadays in experimental pharmacology also different tools are available. Experimental pharmacology is there. Experimental pharmacology is there. So what is virtual experimentation in pharmacology? This is also called in silico. Why in silico method? Because you are working on silicon chip. Silico has came from silicon chip, your system is having silicon chip, so you are, whatsoever you are performing with the help of computer, that will be called in silico. So when you are performing a practical with the help of system, that will be called in silico or virtual experimentation. So now in virtual experimentation, there could be two dimensions. One is software development and another is application. As we are from pharmacology field, basically from pharmaceutical or veterinary or medicine, so we will be mainly concerned over application part. So in application part, we would be more interested in what are the experiments which can be performed. So at present, the software available from Bureau for Health and Education, I think D.Y. Patil University is also using. So we have collaboration with PETA. PETA representative is there, from D.Y. Patil sir is there, and of course very soon we will have collaboration with Sri Lankan bodies also. We will be very much positive for that. So different experiments, whatever can be performed, are listed here. Why I have mentioned here, see, you can see how much comprehensive coverage you can give or you can perform practical using AI enabled software. So different experiments are there. If you are from B Pharm or M Pharm or MD pharmacology, you must be having these practicals in your syllabus. So they will have more connect with you. So all these practicals which are listed here, analgesic activity, then antihistaminic activity, muscle relaxant activity, CNS depressant activity, this sedative effect, electroconvulsometer, number of experiments. I am just scrolling. So effect of different drug on frog heart, then diuretic activity, anti-inflammatory activity, leg and drop apparatus experiment, then dog BP experiment, DRCs, then different type of DRC, PA2 value calculation, PD2 value calculation, anti-ulcer activity. The meaning of showing all these is like how comprehensive it has grown. Long ago, 3-4 experiments were there for that in silico option. But now, if you will go with Bureau for Health and Education Experimental Pharmacology, you will get 87 group modules. 87 group modules, it means it will be containing around 105 or 106 modules. Basic helping modules are also there, like dose calculation, calculation of kinetic parameters, simple techniques, videos of them are also there. So, and examination mode, what is there in the examination mode? Their application of AI comes. In examination mode, you will not be having the drug name known to you. Sample 1, sample 2, sample 3 will be there. You have to select sample 1 and then you have to download your report, and based on that you have to give your answer that which type of drug it could be. And that also will be dynamic. Automatically the sample will be changing. So their AI application is there in the software. Necessary as per Pharmacy Council of India, NMC, VCI, Veterinary Council of India. And basically the software is for this pharmacy, medical, nursing, physiotherapy, whosoever is related to pharmacology. How to get the software? Simply you can, just one moment. Simply you can get the software by writing Bureau for Health and Education in your Google, or heb-nic.in, Health Education Bureau Experimental Pharmacology Software. So that page will appear, and in that page you can perform the practicals. You can get the software online by filling your name and other details. You can get the software link to your mail also. Advantages: first of all, the animal cruelty is being prevented. Number of experiments can be performed in a shorter duration of time. Cost of maintaining animal is reducing. Test reports are available there will be a panel. You can save your reports. Whatsoever practical you have done, you can save. So always your performed practical is there. Otherwise, if you have done practically, so in your record you might have written, it might be lost sometime. But due to digital tool, it will always be saved with your system. So these were the advantages. Although I thought that we will see some modules that will be more interesting, but due to lack of time and some other issues, so I'll be concluding here. And the purpose of showing all this was to prevent cruelty on the animal and to give you a tool which will help you in understanding number of experiment in shorter duration of time. See, if in older days dog BP experiment means it requires 5 to 6 days. With the software, in half an hour you will perform, or maximum 1 hour dog BP experiment. So likewise you can perform number of experiment with the help of software and your time will be saved. And above all, we are saving these animals also. We are human being. God has created them also. We should have heart for them also. And this session will be useful if after this session we could have saved 10 animals, 10 rat, 10 mice, 10 guinea pigs. Then the purpose of this session will be great. Thank you. Yeah. If any query is there.
Thank you. Thank you very much for an inspiring talk. I would like to ask how large were your data sets to build these models, or were them theoretically completely, I mean, physics-based or some kind of this?
Fixed data sets are there, ma'am. Actually, this tool has been created for teaching purpose only. Means for unknown sample we cannot give a great number of data set. Fixed number of data sets are there. Those are available, and basic purpose is at UG level to avoid cruelty on animals. Like at UG level, if we have kept 5-6 data set of responses, suppose Rota-Road experiment is there, we have kept for suppose 50 rats falling time we have kept in the data. That will be reoccurring again and again.
Okay.
But for unknown drug, this will not be useful.
Okay.
For unknown drug, they have to perform their research. But at UG level in India, different regulatory bodies have also promoted this software to prevent cruelty on the animals.
Thank you. Thank you very much.
Ashif Bhatwadekar from Indiana University. To follow what they were asking, is it that there is no animal anymore?
Yeah. Yes, I understood your question, sir. At undergraduate level, 90% it has been replaced with the software. Okay. Means suppose in India, suppose 700 or 1000 medical colleges are there. So among them, 800 medical colleges at MBBS level are using computer assisted learning lab, experimental pharmacology software from bureau or from any other agency. But 80-90% is covered at undergraduate level.
Okay, is that true for School of Pharmacy as well?
Yeah, for pharmacy also 80% schools are using. Although, see, in India, in addition to B.Pharm, D.Pharm course is also there. And D.Pharm course has certain limitation. D.Pharm course owners have their certain limitations, so they might or might not have been used the software or purchased the software, but that is for sure that animal cruelty is not being performed. Animal cruelty is controlled up to 80% in pharmacy colleges also, at undergraduate level. Yeah.
As you said,
yeah.
I work on eyes, but like we could get eyeballs from the abattoir, like the one they are not actually used.
Correct.
So at that time, students can exposure because cutting the eye, it's doing it on. There is a lot of that. So
Yes.
still adopting. I think that.
Yeah, your point is
Yeah.
correct, and regularly we are means refining the software, sir, to match that requirement, and always performing practical on actual animal will always be different from this virtual. But to prevent cruelty, as much as refined software we can offer to them, like that. Yeah. Yes. Thesis and research work, that will be one another dimension of research. But different AI tools are there which you can use to see the previous papers published in literature review. But I will suggest that using AI should be in controlled manner, particularly in research. Otherwise, your complete research will come through AI. So performing it practically is also required. So although you can use the AI for literature review or searching previous papers. Yeah. Yeah, that only.
And all the papers were written by ChatGPT. So, so whenever you use for different type of literature service,
Correct. It should be in controlled manner. Yeah.
Anyhow, before we call upon the last speaker, I just want to, because it's such a wonderful topic, it's a very 2 days back only, such an agenda, as well as Google gave our both are from our area only. They said, don't you believe blindly in every area. Actually, we need to work on that balanced way. How smart it is to make use. You should be smart. We know to charge your money. But are we charged? Are we charged? That is what is good. Don't make it blindly, but use smartly. That means it's a double-edged sword. It is a double-edged sword. We need to know the implications of AI, where to use, when to use, how to use. Till then, we can't say it is ultimate weapon. We have to keep it. I think last speaker will.
Thank you, sir.
Thank you, Dr. Ahuja, for an insightful and forward-looking presentation. Your discussion on the integration of artificial intelligence in pharmacology provides a compelling vision for the future of drug development and research. Now I request Dr. Rohit Bish to introduce our last speaker.
Thank you. Well, my talk is a bit different from the theme of this session though. But what we have been talking about so long about animal research, so ultimately is the benefit going to the last person standing in the queue. So my topic is about that and aligned with the theme of this conference, that is how we reach Viksit Bharat and how youths can play a role and what about pharmacology. So we can see then when we target to reach Viksit Bharat in 2047, and it's very much aligned. You know, development is not just building, making roads and infrastructures and buildings and all these things. It's also about reaching out health for all, which is WHO goal and which actually the Bharat of today it is very much aligned with. And despite our very vast progress, we have made vast progress in every field, and noteworthy is our progress in pharmaceuticals and progress being a medical tourism hub in the world and leader in vaccines. We are providing, when we used to take vaccines once a time, and now we are vaccine givers to the whole world. Still, there are some gaps in medication safety and rational use. And safety and rational pharmacotherapy, largely it's confined still to the tertiary care. Whenever we're talking about rational pharmacotherapy and safety, still today we are talking only about tertiary healthcare settings. And my talk is a continuation of my last talk in the last IPS conference where I talked about, I introduced this concept of community pharmacology. So our issues are with medication errors, irrational prescriptions, and poor adverse drug reaction reporting, where we need to apply these pharmacological principles. We have been learning these things for a long time now, and are we prepared to apply these in the community settings? And here comes the role of community pharmacology. So we have tried to define this. You can go through our publication last year's, where we have defined this new term of community pharmacology in this publication. You can go through, you can type community pharmacology and DEB, and you will find it. So it is an interdisciplinary field applying pharmacology in public health practice, where safe and effective rational pharmacotherapy, it can be applied at all healthcare tiers. We talk about medication management, pharmacovigilance, antimicrobial stewardship, formulary, how we can discipline the formulary management at the PHC level even, and how cold chain can be managed there, and whether patient education and caregivers are being educated. Can we work on all these levels? And best thing which we can see, I can congratulate the organizers to take this theme as this year's conference, because youth actually constitute a huge lot in India, and they are going to contribute immensely when we target to reach Viksit Bharat in 2047. All our goals, be it Ayushman Bharat, be it digital health mission, all these are aligned with youth empowerment. So our national priorities: digital public health goods, productivity, human capital management, universal health coverage, and all these can be actually reached if we actually take up the principle of community pharmacology seriously with antimicrobial. We are talking about antimicrobial containment. Very recently, we saw the government of India taking it up very seriously, but we can actually reach it if we can take it up to the community level. There are access gaps still in our country. I have said we have made a huge progress in pharmacology, pharmaceuticals, but are we able to reach to the last man in the queue? That is where pharmacologists of today, the pharmacologists of tomorrow have to think how they can contribute. And still, a huge expenditure of our people is going from what is called out-of-pocket expenditure in healthcare. We have to think about that, because people are still spending a lot of their savings in buying their medicines and healthcare. And this can be filled with, if we are able to empower the youth in every field, going down to the villages, if you can empower them and enroll them in our community pharmacology initiatives. So medication safety, antimicrobial resistance, immunization, all this can be covered nicely. So what are the foundations? When we talk about quality care, I'll give you a simple query. Say two families have admitted their patient in a hospital. Family A, the patient, he came up with a disease. He recovered a bit, but it's not totally cured. He has to go to a higher setup. So there is a family A. And the family B, he came up, say, with fever, and now he is going back with DILI, the drug-induced liver injury. So what do you think, which family will have more complaints against the healthcare center? Any answer? Family A, not fully cured, and family B is going back home with DILI, drug-induced liver injury. So, of course, yes, family B will be have more complaints with them. So now, so therefore, how we can reach about? So it's not about just effectiveness of our healthcare delivery system. It's also about safety, which is a priority out here. So how we can reach that? Are we able to do medication management, going back to the basic healthcare system? Are we able to do clinical governance? That is, are we able to implement the protocols? Are we able to do audits even at the PHC level? Are we able to do continuous, are we going for continuous skill development of our healthcare workforce? So how we can do that? And our policy alignment is very much with it. So I'll straight away take you how we can do that. So youth participation. Yeah. So youth participation can be, so for example, in pharmacovigilance. So here I'll not go too much into the slides. So I have written here TTWVAA. This is a 6-step approach of active surveillance. It's called, we have published this. It's Dev's active surveillance and assisted reporting model of adverse drug reaction reporting 6-step model, where we talk about T means forming a team, then training the trainers, work distribution, physical visits, assisted reporting, and active surveillance and analysis. So I'll give you 2 examples how we are trying to implement community pharmacology. One example, we tried when there was COVID and the COVID vaccination was going on. So we tried to go to each of the vaccination centers. We enrolled the caregivers of the whole district. We did it at Karnal in Haryana, whole district. And we enrolled them, and we tried to physically apply these 6-step principles to monitor the early responses of any adverse effects from Covaxin and Covishield. And secondly, we implemented this in mass distribution of medicines in large scale. For example, for albendazole, you know, in schools it is given, albendazole as mass administration of albendazole once in a year it is given. And there we tried to enroll all the school teachers, government school teachers in the district. We went there, we did trainings, and we did follow up with this 6-step approach, and we have published this 6-step approach. Anyone can get back to me to have the full details. So youths can be involved in antimicrobial stewardship. If we actually want to be successful in antimicrobial stewardship, which we are talking about a lot today, then we have to enroll the youths at the community level. The youths today, they are educated. So if, say, in any family, most of families will have one person who is has passed 10th or 12th, we can very well enroll them as community pharmacology Sathi or community pharmacology Mitras. And they can be trained and they can actually implement, they can tell the people in their community how to use the antibiotics. Otherwise, we are not going to achieve it. It will remain in seminars and workshops only. And formularies and generics, we are talking about generics, how we can implement that. It has to be done at the community level. We have to see whether the PHCs, whether the CHCs, are they working, are they prescribing on the basis of formularies they have. And another important thing is that expiry dates. How are we monitoring the expiry dates of medications? We are not even doing it at big hospitals. How are we planning to do it at the PHC level? Can we use digitization to where there can be some pop-ups? We talked about AI and all. Can we have some pop-ups which can tell us that, yes, this stock of medicine is going to expire after 2 months? Can we do something like that? The young minds, they can think about. We can develop some apps which can be easily implemented in the, everyone has got a smartphone. Even a person at the PHC, even a Safai Karmi at the PHC has got a smartphone today. So can we empower this huge workforce that we have with some, we can develop some apps and we can empower them to help out there. Yeah, so this is my implementation plan, which we are trying to do. And at AIMS Kalyani, we have already sort of developed a cell on training and community pharmacology cell, when we are trying to improvise it into a center of community pharmacology excellence. So hopefully on 1 or 2 years, we'll be able to bring it to you. So the implementation model is something like that, where it will have a within 18 months, actually, we can empower a district in this model. So phase 0, said 0 to 2 months, we can do site selection, we can have youths and do some fellowships or small courses and all we can do. In phase 1, 3 to 6 months it will take, baselines, SOPs can be prepared quick, you can do some quick wins, cold chain, generics, this can be implemented. And phase 2, 7 to 12 months, we can have assisted, whatever I talked about, the 6-step approach, assisted pharmacovigilance can be implemented there, and audits, etc. can be conducted. And phase 3, all blocks, you can reach out the whole district. So we need government involvement, we need academics. Say, in every medical college, we have pharmacologists, we have MD pharmacologists, we have even we B Pharms, and everyone we have. So can we make a network where a medical college can adopt, say, 20 PhCs, like that, and we can have a network of that, and these pharmacologists who are sitting out in the medical colleges, they can implement their expertise in pharmacological principles in the periphery. We can conduct trainings at the PhCs, we can involve the national service schemes where youths are hugely involved. Can we have some MOUs set up with them, and we can have digital implications there. So community pharmacology is bridges pharmacology and public health, youth driven, it can be safer and cost effective, and we can reach out to Viksit Bharat. So take home message is, safe and rational pharmacotherapy is a national priority today. So empowering youth, it will ensure that the last person lying in the queue, he gets the benefit of our initiatives. Community pharmacology is safe medicines plus skilled workforce plus sustainable health. Viksit Bharat begins where safe pharmacotherapy reaches out to everyone. So what we can do is, I like to say that youth people, if you are interested, you can get back to me, and we can have some online sessions and all, and we can actually tell you, you can take small steps where you are. So you can start with one PhC, you can start with one CHC, and you can see how you can implement your expertise there. Thank you. Yes, sir. Yes, sir.
Yeah, I have a question. Yeah, very nice talk. This is Ashraf Bhatwardekar from Indiana University. I was wondering about the safe and rational pharmacotherapy when you are saying. One of the things I think is missing is like the reconciliation at the pharmacy. Not having a common model like the medicines which are given, I think they're not really reconciled at the pharmacy level. There is a lot of drug interactions there happening. So do you have any suggestions on that?
It was one of our slides. I was about to talk about that. I could not because of the shortage of time. When you talk about reconciliation, see, then you need first thing for that, because a person who is an expert to do reconciliation, today he's sitting out at the tertiary care level. Do you agree with that?
No, I don't. The pharmacist can do that.
Yeah. My point is that, are they trained enough to do reconciliation
Of
today?
course, they are.
I beg to differ. The present workforce which is there at the PACs and CSs, are they trained enough? Because maybe they have got those degrees and all, but are they trained enough? And even I like to say, if I do not practice reconciliation, I will not be able to do after 2 years. So we need trainings on reconciliation. Obviously, your point is very taken. If we can do some actual trainings, ongoing trainings for our workforce, definitely we can do reconciliation, and we can actually prevent ADRs, we can prevent AMR, but we have to do it. My point is, we have to do it at the community level. We have to do it at the last healthcare tier.
Yeah, I think that's where the means if we have the model where like Dr. A, Dr. B, Dr. C, and it is filled at a place where all the Dr. A, Dr. B, Dr. C medicines are seen at the level, and then you can do the drug utilization reviews, and then I think that way we can have the safer and rational pharmacotherapy.
Obviously.
Because currently there is no way unless patients are telling, but I think at their level they are not educated enough to know that, hey, these two drugs that I'm taking, whether they are interacting like.
Yeah. So that is what I'm saying, that can we develop we can develop some apps which can tell them that these two medications, if they're using together, there is chance of interaction. Or something can tell we can do a scan of the prescription which is written, and then that can tell whether some mistake is there or not. So can we implement all those things? Thank you.
Thank you, Dr. Dev, for your insightful and interesting presentation. Your discussion on the role of youth in health ecosystem provides a compelling vision for the future of community pharmacology. We are honored to felicitate our esteemed chairs, Dr. Mahendra Bishnoi, Dr. Rohit Bisht, and Dr. Vranjanelu, and whose guidance and vision has elevated the stature of this gather. We express our deepest appreciation. I will now request Dr. Manish Jain to felicitate basically our esteemed chairs. Yeah, I will request Dr. Bishnoi to felicitate basically Dr. Adam Jissing. Now I request Dr. Virenjanelu to felicitate Dr. Kalpani, basically Ratnake. And finally, I will request Dr. Rohit Bish to felicitate basically Dr. Dharmendra Huja and Dr. Tirthankar Deb. With this, we bring Symposia 7, Preclinical Pharmacology, Navigating Translational Challenges and Ethical Considerations to a formal close. On the behalf of the organizing committee, we express our deep appreciation to our respected chairs, all distinguished speakers for their exceptional scholarly contributions, all members of the audience for their gracious and attentive participation. We trust that their deliberation of this session have enriched our collective understanding and inspired further commitment to the challenges and considerations in preclinical pharmacology.